Hey, everybody.
Hey, guys.
Hey.
Hope everybody's
Hello.
doing well. We know your time is valuable.
Good
We
morning.
appreciate y'all being here. Last day before the exam. So here's the agenda. We're just going to kind of go through everything, all the high yield stuff. We're going to go pretty quick because we know y'all want to get off to go studying. That being said, we're going to record it. So if y'all want to go back and look at anything in particular, y'all are more than welcome to. My name's Brady. I'm term 5. I'm the Honor Society president at SGU, and this is my co-facilitator. Introduce herself.
Hey, guys. I'm Lindsey. I am the SGA, Student Government President of School of Medicine Affairs. And so Brady and I have been, also term 5, Brady and I have been doing this since our term 2. We just like to give back to the SG community because so many people helped us when we were transitioning into the stage of life. Again, as always, all of our sessions are just 2T5s paying it forward. This has nothing to do with official DES, so it will not fulfill any of your requirements. We want to help you, and we want to help as many people as possible. So that's why we do this. But just some stuff for the session. If you have questions, put them in the chat to everyone. You can reach out to Brady and myself privately. If somebody is talking, it's probably good to message the other person because the person talking can't really check their messages. But if you put it to everybody, it allows everyone the chance to both see the question and see the answer, but it also gives other people a chance to answer. So if you guys want to answer each other in the chat, do so. Peer-to-peer learning is a huge thing. And if you know the answer to somebody's question, don't hesitate to talk about it in the chat. Like, you don't have to hear it from us. So yeah, I just want to encourage talking in the chat, asking questions in the chat, and we will try to get to every single question. If you do have a question during the session, we encourage you to ask it. Probably raise your hand though, so you're not interrupting and we have to stop. But yeah, just raise your hand, the raise function in the reactions. But yeah, we are so glad you're here, and it'll be fun.
Yeah, this is informal, so we could talk about things, we can discuss things. We want you to come away with this feeling comfortable about tomorrow. Ideally, much of this will be review. We just want to really focus on some of the high points, some of the things that we've seen over the past few terms that are often tested. Okay, that being said, I'm going to share my screen. We have a couple of housekeeping things that we do for you guys just to see and before we get started. So if you are familiar, I run Scrubs, Lindsey runs Dog Mom DES. So what we do here, so your slides will always be posted on both of our pages. And these are what we're going to use for the review. Also, we have the YouTube channel, which we post all of our reviews on. It's private, so you have to use this link. So in the About section, you go to term 1, use this link. If you bookmark it, you'll have access to all of the slides. It'll bring you here. So these are all of the term 1 reviews we've done through the last couple of terms. Your review will be up here. If you weren't able to watch the advice session, we kind of went through some of the way we study and how we approach the material. So maybe after the exam, if you haven't seen that, it'd be good to go look at that. So yeah, and then also, like Lindsey said, this is not affiliated with school, but I am the IEA, the Honor Society president. So y'all should follow IEA on Instagram. We do questions of the day every day for your term and all the other terms. So it's pretty cool. It's a good way to check and see if you're keeping up with some of the high yield material. So follow us there. We'll also post the tutoring forms once we get all of our members approved. Next term, if you get above a 90, you'll be able to apply to IEA. And so there's a lot of benefits there. So definitely follow IEA. But again, this is just me and Lindsey doing this on our own. There's no affiliation with school.
Yeah.
So
also follow SGA. We have an Instagram page as well. And we also have a Facebook page that you can like and follow and get updates that way.
All right. Yep, go ahead.
The lecture slides are posted on both Brady and my my pages right now. So you can go to either Dogmom DES, Scrubs DES, and the slides are right there.
Okay, so the way we format this, as we go along, when we get more into the system-based material, cardio, renal, stuff like that, it's more of a discussion-based approach. But right now, because you guys need to get used to the way these questions are worded, and we do these a lot based on questions. We want you to get into the mindset of answering these style of questions. So it's one thing to know the material, but also there's an art to answering these questions. It's like playing sports. The more questions you do, the better you get, the faster you get, the more confident you get. There's things such as there's no all of the above, there's no multiple answers. You have to pick the most correct answer. Like, this takes time and practice to get better at. And if nothing else, your confidence will go up tremendously. So, and you'll see as you go along, you start keying in on certain words in these vignettes and stuff, and you'll be able to get more confident with these style of questions. Okay.
And when we're doing the questions, to answer the questions, please post it privately to either Brady or myself. The reason being, we want everybody to be able to read the question and answer it without seeing other people's answer choices. So if you're answering one of the multiple choice questions that we have in our session, just please put it privately to Brady or myself.
Okay, these are our pages. Follow us on Facebook. That's the best way we can communicate with you guys. And as always, if y'all have any questions, y'all can always message us. We'll try to get back to you as soon as we can. Also on our pages are access to our Google Drives. We post a bunch of good resources that we've come across over our time here. Some people like to learn from tables. Some people like extra. As always, you should do extra questions. I post all of the old IEA honors questions on here too. So go on there and thumb through it and see what works for you. All right, so briefly we'll look at this, but we want to focus on your exam. These were kind of some of the key points we talked about in our advice session. Things such as not falling behind. Remember, the DLAs are just as important as lectures. And as always, more questions, the better. The best correlate to how well you do on the step they've shown is the more questions. The people that do more questions tend to do better. It's like a linear distribution. So you should definitely keep that in mind. Some people like Anki, the flashcard system, it takes a little bit of getting used to. Lindsey and I don't really use it, but some people swear by it. As always, everybody learns differently. So the way I do it, I'm a heavy post reader. My first post read is all about understanding, right? So I don't sit there and memorize charts for an hour or whatnot. I want to go through the whole thing. And by the time I'm done, I want to be able to put up the slides and be able to explain it to someone. Okay, so the more you can understand, the less you have to memorize. The things that fail you on the exam are the stuff when you're stressed out, are the stuff that you had to bury in your mind for memorization. So the more you can understand, the better you'll end up doing. That's the stuff you're going to retain over the years, is the stuff you can understand. So that's my approach the first pass. And then my second pass, I'm going into the fine details with a fine-tooth comb, trying to memorize some of the smaller details. But at that point, I have a general understanding of what I'm working with, okay? So that's just the way I do it. But again, everybody's different. Lindsey likes using Boards and Beyond. Do you want to speak on that real quick? All of, what you like to use?
I actually don't use Boards and Beyond.
Oh, Osmosis,
supplemental resources. I like Osmosis. I really like Ninja Nerd on YouTube, which is free. I do use Physio. And so however, I usually don't go to my supplemental resources unless I feel I have to, because the testable information is all from the lecture slides, and the lecture slides only. And so when you go too much into your supplemental resources, especially in term one, in year one, you risk learning more than you need to. And so stick to the SGU slides. If you feel like you need to expand on a concept or you don't understand something, then I go to my supplemental resources to see if I can find something. But Osmosis is a really good resource. Ninja Nerd Science on YouTube, or if you just YouTube something and see if it comes up, honestly, that works a lot too. If you don't already subscribe to some supplemental resources, but you want to, I suggest doing some free trials. Honestly, see what you want to invest in, because these resources are not cheap. And if getting too many resources will not be in your favor, but you need to stick with what you like and what is going to work for you. So do some free trials if you want to do that, but always stick to your lecture slides.
And as you can see here, first aid, this is the Bible of medicine. For us, at least, the sooner you start looking at it, the better. It's very dense in that it doesn't explain a lot, but it has great tables and great summaries, in a sense that all the high yield material is there. It's the first book I always go to. It tells me exactly what I need to know. So the sooner you do that, the better. But let me stress again, and you should start right now because it's going to help you throughout. The more stuff you can understand, the more stuff you can explain to another person, the better off you're going to be. Okay, like as the material gets denser and denser, some of the mnemonics that are helpful, some of the just the memorization you have to do the day before the exam, that's not what you want to completely rely on. It is inevitable that it comes down to that at sometimes, but keep in mind that understanding the material is like is the top of the peak, right? You want to be able to explain this and understand it so that when it comes up again later on next term, next year, you have a basis of understanding. Okay, now this is important, okay? Especially at this point, I'm a robot when I take tests. There are no emotions involved. And Lindsey and I take tests the same way. Every test is exactly the same. I go through every question. I answer every question. If I'm not sure about it while I answer it, I flag it. Okay, so I go through the whole test like that. My second pass, I just go through the ones that are flagged. I check it again. And I only change my answer if I'm blatantly made a mistake. So I've done large question banks where they analyze you, and it has shown that more often than not, when I change my answer, I change it from right to wrong. I would assume that many of you are the same. It happens. So I have a steadfast rule. There are no emotions, right? So unless I'm blatantly made a mistake, I never change my answer. Okay, so that second pass, I just go through the flag ones. As I do them, I unflag them. And then, so my third pass, I just go back through from the beginning and just look one last time. Every single test, all the time. The more systematic you can be about it, the less the error rate. Okay, so it's not a perfect system, but my goal is to focus, use my frontal lobe, not my emotional cortex. I don't want to be thinking about there were 4 D's in a row. I can't put a 5th D. Like, that's nonsense.
Yeah.
Like, every test, like, everything's independent. Like, none of that is involved. Okay, so we could go through this quick. Watch the clock. So you get 72 seconds a question. I try to limit myself to 1 minute. If I can do every question in about a minute. Some go over, some go under, but if I keep it about a minute, then I have time to go back through my second pass with the flags and the third pass through everything. Okay, so that's you want to keep that in mind when you're doing practice questions. You should try to time yourself, keep it at about a minute. There's the highlight, the strikeout function. I use those. You highlight keywords, buzzwords. FTM is heavy on buzzwords. So you want to highlight those. It'll help when you go back through and check stuff. You don't have to read the whole passage again. So just as you're reading, it kind of slows you down too. So you don't have to go back to the question. Sometimes when I first started out, I'd read the whole vignette and I'd be like, I don't know what I just read. So by slowing down and highlighting specific words, it'll help. Also, the strikeout function, if you know it's incorrect, you can strike it out. That's really helpful, especially when they have questions with a bunch of up and down arrows and stuff. And it's just there's science behind being able to look at striking out 3 and just limiting it to 2, like just seeing it in your brain like that. Always flag the answers you don't know, but what I do, I answer the question the best I can, but I still mark it so that I can go back and look at it. And again, I never change my answer unless I know I made a mistake. There is no whiteboard, so we had the same thing. We were here briefly when we had whiteboards prior to COVID, Lindsey and I, but they sent us home in our first term. Since then, no one's had whiteboards. The school has gone through the process of making the questions, even the math, simpler because since we don't have whiteboards, right? You have to be able to do it in your head. So don't stress. Some of those crazy equations won't be used as much just because they do understand you don't have a whiteboard. And as always, Go ahead.
I want to speak a little bit on the exam protocols. Please, 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 please set yourself up for success and read the exam protocols. They're the exact same as when we were online. There is a monitoring system on your exam soft, and it's an AI that watches you the whole time. If you deviate from the screen too many times, it flags you. So please make sure that you aren't bringing any prohibited stuff. This is more for people at home because they won't even let you, in-person people, they won't even let you into the exam venue with anything that is prohibited. But people at home, please, please do yourself a favor and make sure that you read through the prohibited items. You make sure you read through the exam protocols. You can't read out loud. So if the AI hears you reading a question out loud, it flags you. If you're wearing glasses that have a reflection on them and they can't see your eyes, it flags you. If you're in a too dimly lit area, it flags you. And so you can probably lip read, but don't read it out loud. Don't like talk to the computer. Just so actually, you know what? Don't lip read. Try not to lip read. I'm not gonna, I don't want to tell you guys something and then it gets you flagged. Blue light glasses are fine because it doesn't have the glare. ExamSoft does have a calculator. Yeah, so the process is you will get flagged, and if you have too many flags, then the university gets a report and they will review you. They'll review the footage. If they think that it is it's an actual violation, they'll email you a warning, as long as it's not a gross violation. But they'll email you a warning. It's simply that. It's just a warning. I don't know about masks, honestly. But if you need to go to the bathroom, it cuts into your time. There are 3 separate blocks. You will get a break in between. However, you cannot look at anything in between. So you can't get on.
Time out, Lindsay. Just to clarify, you can, if you're at home, you can't go to the bathroom in the middle.
Oh yeah, no.
That's if you're in person.
No. Yeah, if you're in person, you have to raise your hand. The facilitator will come. You'll pause the exam. You go out and it'll cut into your exam time. If you're at home, do not leave your computer. Do not leave your computer. That is a huge flag, and I don't even know if you would get a warning. You would probably get a penalty at that point.
But ideally,
if you're at home, you can look at notes in between, but if you're in person, you cannot. They don't let you, I heard.
I think people were, okay, I'm not positive, but I think people had breaks. Okay, I'm not positive. Okay, yeah, looks, but even if you're in person, just, you have blocks that you have time in between. So like, try to go to the bathroom then, so you don't have to worry about it during your exam. Like, and don't freak out about this.
Only an hour.
Yeah.
The block's only an hour.
So. Don't make too much about this whole like ExamSoft watching you. Just look at the screen. Like, don't be weird. Yeah. Like, right. So just look at the screen. But this is your first
time, and so I want you guys to be prepared, because I don't want you to get very casual with the ExamSoft monitor and then you get flagged. So that's why I'm being a little cautionary right now, because you guys haven't taken an exam under these conditions before. And it takes a couple times to get used to just sitting there and staring at your screen the whole time and not looking away. Because even if you hear something off to the side, your automatic reaction, your reflex is to look at it. You might not get a flag for that, but I'm just saying, I want you guys to be cautious. I want you guys to read through the protocols, because if you don't read through the protocols and you do get a violation, that's the worst case scenario. So please read through the protocols. They were emailed out by your course director. They're in your learning pathways document. They're in your syllabus. So please read that to set yourself up for success. Sorry if I scared anybody.
Just stare at the screen. You'll be fine. All right, so just things that are important, always note differences. Some diseases present very similarly, and the only way to tell the difference is doing labs. So those labs will be important to know. Things that the professors specifically say, especially early on when you're starting out, they'll literally be like, this is an important slide, you need to star it or something. So that's important. Clinically, of course, you're trying to be a doctor, you're on your way. So things that have to do with the diseases are going to be important. Sometimes the best way is to take the disease, which usually presents at the end of lecture, take the disease and work backwards, right? Cystic fibrosis, what's the problem? They get mucus buildup. Why is that? Because the chloride channels are flipped. What's that mean? The water and salt don't go out, so the mucus builds up, so they end up with pancreatic problems and lung pathology, lung infections, things like that. And why is the chloride channel flipped? Because there's a genetic mutation in the CFTR gene. Okay, so you kind of need to take the disease and work backwards all the way to the genetic level. Okay, if you do that, you should be fine. I know it's easier said than done because some of these questions are third and fourth order, right? So if you miss any step through that process, you may not get it right. But you will get used to it. As I said, a lot of this first two tests are going to be buzzword heavy. So things that'll immediately key you into what we're talking about. As always, do the question on Sakai. Those teachers that are writing the questions, write the questions on Sakai. So that's a good representation of what they feel is important. I always go back through the IMCQs as well the day before the exam. So that's good. All right. Yeah, you could read through this on your own. A big thing is when you're stressed and reading really fast, sometimes you miss the not in the sentence. It happens, highlight it, make sure you know, because that will flip your answer around, right? So there's technically no right way to do this, but I promise you the more systematic you get about it, the less stress you'll be. Test taking anxiety is a real thing. So you will get better with it. This is all a learning experience, but by limiting the variability between how you do things and being more systematic, you'll do much better. All right, so yeah, go ahead.
I'm going to answer a question that was directed at me towards the chat, but I think it's a good question for everybody. 20 experimental questions. What is an experimental question? Don't worry about the experimental questions. They do not count for or against you. They're just that they're experimental, and they are used to track statistics on questions that have. So the exams are made up of questions that have statistics over time. And so the statistics will add together, and they're going to calibrate the exam to an average of 80. So basically SGU is saying that this based off of the questions we picked and the performance on these questions in the past, the average should be at an 80. Experimental questions don't yet have a statistic. They don't yet have a statistic. And so those questions are put in there to get the statistics. They do not count for or against you. They're just there. And so even though you have 48 questions per section, and it adds up to whatever, I'm not going to do math and embarrass myself right now. Those questions that are experimental are not even counted in your grade at all. So when you look at your scores in Sakai, they're not even there. So just be cognizant of that. Don't worry about the experimental questions. The only thing it does is after you leave an exam, if you guys are thinking about a question that was like crazy hard, you're like, okay, maybe that was an experimental question, but don't worry about them. They don't really concern you. They're really just for SGU to test out questions.
Right. So basically, if your exam is 144 questions, it will actually be 124. You will be graded on 124. This statistical question bank that SGU is developing is very similar to how the STEP does it, right? So they want to be able to take a selection of questions, some easier, some harder, as Lindsey was saying, to kind of gauge it at about an 80 over years. The more people that use that question in that test, in certain tests, the better analysis or analytics they have on it. Okay, so by the time y'all are taking this test, they should be able to write a test that stands at about 78 to an 82, right? Because they've used some of these questions before. Let this be clear. There are no shortcuts. If you are looking at old things that people have given you that are representative of the test, you can use things such as old advice as to see if you understand the questions, but understand every test is written independently. There are no shortcuts. If there were, we would have figured it out by now. Okay.
Yeah, everyone would be honored if we had figured out the shortcut.
Yeah, so just be warned, okay? Now, let's get some of this, let's get into the science here. Now, a couple of these questions are not written as vignettes. We get it. We did this because these are some of these random things that they just love to test on. So as you can see here, we're talking primary cilia and cilia. What are cilia? Typically, when you think, at least in the respiratory tract, they're unilateral. They swing upwards to help pull the mucus out. There are different types of cilia, but it basically, it guides movement, right? So when we talk about primary cilia, we're talking about the 9+0 arrangement. And when you talk about the actual cilia that sticks up, it is the 9+2 arrangement. Now, if you look here, if you see this little electron micrograph picture right here, this is a cilia. So you see 9 triplets and 2 doublets in the middle. You can see the arrangement here. This is a very important, I'm sorry, it's 9 triplets and 2 singlets. And you can see the arrangement here. This is a very important micrograph, electron micrograph to be aware of, okay? So that that has come up. So yeah, so you can either have them as a motor complex, right? But there's cilia in the kidneys that are sensory. So it'll help to to sense the flow against the kidneys in certain areas. And if it's too high pressure, too high of a flow, it'll help to bring down your blood pressure by getting rid of more fluid. So you'll get to that later, but just know that these are complex structures that help with either motor movement or sensory component to mostly recognize fluid flow. Now, this is very different from, well, we'll get there in a second. Let's just, yeah. All right, so go ahead and answer this one. Awesome. Yeah. And for the sake of time, we're not going to give you 72 seconds or even a minute for some of these because we want to get through this so y'all can go back and study. What I wanted to bring up before, so don't get cilia and microvilli confused. Microvilli are typically found in the intestines. They increase surface area. Okay. So the more surface area, the more absorptive capacity you have in the gut, right? So by having those little microvilli, so those are usually in regards to absorption, whereas the cilia, like I mentioned, either have some sort of motor component to sweep mucus out of your respiratory tract, or some sort of sensory component that has to do with regulating flow, and specifically water. All right, so these are lipofuscin granules. They're not really, there's no pathology behind them. They just develop over time, okay? So this is known as the wear and tear pigment, which means with age, you should see more of this. So a question would be, and you'll get better at this because sometimes keying in on the age, sometimes when I read it, I skip over the age and it's not important, but then as I see what the question's about, such as this, I'll go back and see, because if they're talking about this, this should be an elderly patient, right? Because you would see more of this. So it is good to key in on that, especially specifically if the patient is very old or very young, because there's a lot of pathologies that are involved specific to them, right? So just keep an eye out for that. When we talk about some of these, again, the lipofuscin is wear and tear. Hemosiderin is an iron component that can develop. They have complexes that form. Melanin is in your skin, right? That gives you pigmentation. Glycogen, those are usually, they don't stain on H&E. So they're like big white globules. You need to use PAS to stain for that, and lipid as well, because they're hydrophobic, right? So they won't pick up any charge for the H&E stain. So these are just some of the basic things you need to know about some of this histology. All right, they love this picture. So go ahead and answer this. Awesome, very good. Lipofuscin and hemosiderin, I just had a question here. Right, so yeah, and they do, so hemosiderin technically is like a browner pigment, where lipofuscin is like pinker, but they should give you enough information in the stem to be able to discern it. Like if they talk about elderly patient and this has developed over time, you're thinking about lipofuscin. They do have some diseases that y'all will get into later that have to do with iron deposits, but if anything, they'd probably put that lipofuscin granule in there before they put hemosiderin. Okay, so what we're looking at here, take a snapshot in your mind of this picture because it comes up. What we're looking at is pinocytosis here. If you look right here, pinocytosis in Latin literally means cell drinking. So you can see these little vacuoles here, the cells just picking up fluid, okay? So that's what that is. All right, try this one.
Hey guys, just as a reminder, please directly message Brady or myself when you're doing the MCQs to give everybody a chance to answer on their own, because that's really important when practicing. You want to make sure that you can try to get it without any outside influence. Please and thank you.
And if you have a question, you could speak up while we're doing this,
Yeah.
while it's quiet. Like we said, it's informal. So if you have something you want to mention or ask a question, it's fine. No big deal.
Definitely.
Okay.
Completely informal, remember.
So the plasma membrane, remember, it's a very fluid component, right? You have those hydrophilic heads, and the hydrophobic tails stick towards the middle. Why is that? That's because the hydrophilic, water-loving, needs to be on the outside because there's fluid, right? So it's very fluid. It's a very fluid complex. When you think of cholesterol, it's this huge molecule that they just kind of stick in the middle. So if you put a big, large brick or component in this membrane, it's going to stiffen it, okay? And that is the whole component. If you decrease fluidity or stiffen the membrane, you're also going to decrease permeability, right? Because everything's kind of tighter together. It's a stiff membrane, and particles just can't get through it as easily. But this is a very important component. Now, if they ask you a question, I do believe it will be straightforward like this. But the next slide I'll show you. You will get into a lot of this later because cholesterol has a huge component in all kinds of aspects of the body. But as of right now, yeah, it's going to be part of this plasma membrane to stiffen it. But you can see here in orange, these are going to be hydrophilic. They're towards the outside by the fluid, hydrophobic towards the inside. You can see these large cholesterol molecules, right, that are just stuck in there. It's going to help to stiffen it. Y'all will get to some of these other things, but it's just important to know that cholesterol, people think of having high cholesterol. That's bad, but you obviously need cholesterol in your body for all these different components. Now, here's the tricky thing. And here's the thing about medicine, which is such a pain. Nothing's really black and white. It may seem like it is sometimes, but there's always exceptions to the rule. That's throw everything off. So at low temperatures, cholesterol will actually increase the fluidity. So think of it trying to correct the problem. At low temperatures, you would expect to have a stiffer membrane. Okay. Now cholesterol will try to compensate for that. So if it's at low temperatures and a stiff membrane, the cholesterol will actually increase the fluidity. At high temperatures, you would think a lot of movement, cholesterol will decrease the fluidity. Now I'm just putting this in here for completeness sake. I've never seen a question where they went this in detail. If they ask you, I think they would ask you at normal body temperature, okay? So at normal body temperature, we're stiffening everything, okay? Yes, it does depend on the temperature, a good question, but for the test, they would have to specify, and they probably won't, okay? So I just wanted to let y'all know that this is it's a little bit more complicated than that. All right, yeah, okay, cool. So yeah, try this one. Okay, so this is more of a vignette style question, and I'll give you all a second, then I'll walk you through how I do these. So, well, I'll answer that in a second. Try this question first. All right, let me go back real quick. So so the question is, why does cholesterol decrease the permeability? When you think of the membrane being very fluid, that means there's a lot of space involved with the fluidity. And so that means stuff can get through. Things that are charged, such as sodium and chloride, you need a channel to bring it through. But things such as glucose uses a transporter too. But typically things that are small and don't have a charge can just go through the membrane. So if it's very fluid of a membrane, stuff can get through. But if you add cholesterol to it and you make the membrane stiffer, all of the molecules are closer together, so it's harder for stuff to get through. So it decreases fluidity, it makes it stiffer, and decreases the permeability. Okay, so let's look at this question. I'll walk you through it. All right, first thing, it's a kid. That's an important component to this. All right, so productive cough, upper respiratory infections. Note this, so this isn't exactly a good one, but like some questions, they'll tell you the patient's a farmer, right? They don't tell you that for no reason. Like there's specific things that happen to farmers, or they'll say the patient is a nurse, and it's like they key you in on these things, or they'll say the patient is from South America, right? And there's things that happen in these regions to these specific people or these specific occupational hazards. So key in on things like that. They typically put those in there for a reason. Okay, so she's small, low in birth and height and weight for her age, bulky, foul-smelling stools. Okay, so we got a kid who's having chronic upper respiratory infections, right, and bulky, foul-smelling stools. So we're diagnosing this kid with cystic fibrosis. Again, it is a genetic component, right? It's autosomal recessive. Besides a few exceptions, we should be able to diagnose this as a child, right? Okay, because it's genetic. So we know that because this mucus is building up, because these chloride channels are messed up. So if the chloride channels are messed up, you can't get water across. Water always goes with salt. So because these channels are messed up, the balance is off. And this causes a lot of mucus to build up, specifically in the lungs and in the pancreas. So upper respiratory infection is because you have so much mucus in the lungs. So if there's a lot of mucus, there's a lot of, it's a conduit for bacterial infections. The bulky, foul-smelling stools is because the bile duct, the pancreatic duct is blocked with mucus. So you can't get the enzymes from the pancreas into the gut to help to digest fats. So whenever you see bulky, foul-smelling stools, it tends to mean that there's a lot of fat in it, okay? Or they'll say the stool floats. That tends to be fatty stools, okay? So this is diagnostic for cystic fibrosis. All right, so what's the test that we use for that? You do the sweat chloride test. One of the interesting things that they'll say, and actually happens in real life, is the mom or the grandma or somebody kisses the kid on the forehead, and it tastes salty, right? And that's basically the premise of this test. You check the skin to see if the salt content is elevated, and that could be indicative that the chloride channels are messed up. You're going to learn more about cystic fibrosis as you go. I'm not exactly sure where exactly y'all stopped off, but just in case y'all did talk about this, it's important to know that the chloride channels are always flipped. And that's how they're messed up. But in the skin, they're flipped towards the outside. I'm not sure if y'all talked about this, but if y'all did, that's an important thing to know. Because they're flipped on the outside, all the chloride accumulates on the skin. Okay, in the rest of the body, the chloride will accumulate intracellularly or on the inside. Okay, yeah, this may come up later, but just in case y'all talked about it. Okay, y'all haven't talked about it. Okay, if I ever start talking about something and y'all haven't talked about it, y'all just tell me, okay? Because it's hard to remember where everybody stopped off. Okay, anyway, so good screening test for this is the sweat test or sweat chloride test. And you can see that here, pulmonary infections, the pancreas gets clogged up. They have problems within the vas deferens, right? Because that mucus will build up there, so you get male infertility. Of course, if you can't digest fats, you're not going to develop properly either. They tend to be very small for their age and skinny. Keep in mind, this is a defect in the CFTR gene, cystic fibrosis transmembrane receptor. Okay. All right, try this one. Oh, okay, y'all did come across that. It was in the DLA. Okay. The chloride channels. All right. Yeah, very good. Okay, so what actually defines when a child, well, when a premature child is born, what defines if the viability of the child, if they're going to be able to survive, is this quotient, right? You're depending on the lungs to be able to be developed. And by them being developed, you have to make surfactant. You'll learn about more of this when you do respiratory, but surfactant basically keeps the alveoli open, okay? And I'm not going to get into too much detail with it, but by keeping it open, the alveoli won't collapse. If the child is born too young and they don't have surfactant, the alveoli will collapse and they'll end up with respiratory distress syndrome. Okay, so what you're actually measuring is DPPC. Now, I don't go through, like, it may be great if you could sit, dipalmitoyl phosphatidylcholine, right? But on the test, like, I just remember DPPC. And even if they write this out, I can kind of work it out. There's a DPPC, right? Okay, so if it helps you to just learn some of these abbreviations, that's worked for me so far. So what you're actually looking at is the lecithin to sphingomyelin ratio. Okay, and it's always a 2-to-1. Lecithin is a component of this, dipalmitoyl or DPPC is a component of lecithin. So by having the child, the lecithin to sphingomyelin ratio of 2-to-1, that means their lungs are developed. Okay, so if they ever talk about the lecithin to sphingomyelin ratio, you want a 2-to-1. This usually happens about 26 weeks of gestation. Okay, so you start making surfactant about 22 weeks, and usually the child's viable by 26. Okay, obviously they're still premature, but at least they'll be able to breathe on their own. Okay, and you can see that here, it's a component to surfactant, component of lecithin, and that lecithin to sphingomyelin ratio is what they use to see if there's enough there. Interestingly enough, you can actually give the mom, if you're assuming that the baby's going to be premature, you can give the mom glucose or corticosteroids or glucocorticoids before the delivery, and it helps to develop the sphingomyelin. So that's the treatment for that. All right, so there's a trick to knowing these. You have to know these essential fatty acids. I really like this one. So you see, let's see, where is it? Right, omega-6. If you go backwards, 1, 2, 3, 4, 5, 6, the ends in the 6th position. So linoleic acid is omega-6. If you look at omega-3, 1, 2, 3, the ends in the 3rd position from the back. Okay, because these are so close together. That's an easy trick to remember what goes with what. So these are essential amino acids. That means you have to get them in your diet, right? You can't make them on your own. And these are precursors to a lot of other amino acids that we use. All right. It is great to be able to write this out, but at the end of the day, they're not going to ask you to do that on the exam, right? There's certain things that are really important. Sphingomyelin is important because it actually makes the myelin around the nerves. So you can think of that as like it's just a lipid. It's a lipid outer component to the nerve, so it helps to conduct electricity better. Okay, so that's what sphingomyelin is. So that's why that comes up a lot. There are certain diseases that deal with losing or demyelination that y'all will get to later, but sphingomyelin is a good component. Somebody remind me, which of these is the one that flips in the membrane to determine apoptosis? You could say it out loud. Is it?
The phosphatidylserine.
Serine, there it is. Good. That's an important one to know. All right. So it's on the inner side, and then if it's going to apoptose the cell, it flips to the outer membrane. Am I correct?
Yep.
Yeah, awesome. Okay, so keep that one in mind. We talked about DPPC. So again, if you're looking at this and you're like, what in the world do I need to know? Think about the things that the ancillary stuff that they talk about in class or in lecture. DPPC, obviously important for kids and development. Sphingomyelin is important for nerves. Phosphatidylserine is very unique in that it does this flip thing to signal for apoptosis. So those are the kind of things you want to key in on. I know it's very hard when you start out and you're trying to figure out what's important and what's not. I promise you it gets easier. You'll get better at it. All right. Everybody's favorite. Let's walk through one of these. DPPC, I don't know that you'd really consider it in the plasma membrane, but it's a component of the surfactant, which is more of a fluid that develops. So just keep that in mind. That's all you really need to know about it.
Yeah, its association with the respiratory distress in children is the most important thing for you at this time.
Yeah, bear with me 1 second. I'm gonna draw this out for you all. All right. So again, you're not going to have scratch paper to be able to do this, but I'm going to do it out for you guys so that you get it all straight for the test. All right. All right, let's take a look at this. So the first thing I want you to keep in mind, because this is very important in medicine, is osmolarity. The word osmolarity. When you think of the word osmolarity, you should think of stuff in the fluid, stuff in the urine. It's very concentrated. There's a lot of things in there, right? So if you have checked the patient's urine and you have a high osmolarity, that means there's a lot of particles in it, okay? That could indicate that the patient is dehydrated, right? Why is his urine so concentrated? Whereas if you have something with low osmolarity, it's very dilute, okay? So when you hear the word osmolarity or even tonicity, it means that there's a lot of stuff in it. So high osmolarity means there's a lot of components in it, right? And it's a ratio, right? A lot of components can also mean less fluid, right? It's the same thing. It means it's very concentrated. Okay, so first step is we cannot have any millimolars, right? We cannot have this. We have to convert it first. So this is our first step. So you have to break it up. So you're going to have 150 sodium and 150 chloride, right? You have to do the same thing on the other side. So you're going to have 150 potassium, 150 chloride. Okay. You also need to add this to this side, 300 of urea. All right, real quick, before we continue, I just want to make a point. Let's say we had calcium chloride, okay, millimolars. How do we break this up? You have to break it up in 3, right? Say we had 100 of this. You have to break it up into 3 because there's 2 chlorides. So it'd be 100 calcium, 100 chloride, and another 100 chloride because it's 3 components. Okay, so just keep that in mind. Now, let's do the math here. So first step is you do osmolarity. Osmolarity is what happens in the immediate future. When you put these solutions together, what happens transiently, right away, okay? So we're gonna include everything in our equation, including the urea. So you're gonna end up with 600 on this side, and you're gonna end up with 300 on this side. So we're doing osmolarity, which includes everything, okay? So if you have 600 and 300, let's say this was, what was this, compartment A, and this was compartment B. Remember, fluid's always gonna go to the side with more stuff in it, okay? So fluid's gonna go from this compartment to this compartment, okay? But if we were defining this, we would say compartment A has a higher osmolarity than compartment B, right? It's got more stuff in it, okay? It's more concentrated. Now, after this, we need to do tonicity, okay? Remember, when we do tonicity, we're saying what happens after everything crosses over. We already said ionic components can't cross on their own, okay? But urea is not charged. Urea can cross, glycerol can cross, glucose can cross. So now when we look at tonicity, we're worried about just the stuff that hasn't crossed. So what happens over time is the urea is going to equilibrate. You're going to get 150 of urea on one side and 150 on the other side. Okay, so it completely cancels out. So now we're worried about these charged particles for tonicity. So we have 300 in compartment A and 300 in compartment B, which means it's isotonic. Does that make sense to everyone? Right, osmolarity first. We figure out what has more stuff in it. It has a higher osmolarity, right? So all of the fluid's going to go to compartment A. Now let me bring this up because I got a couple of people email me about this one. It's very similar. So I think it was like we had 10 liters of fluid on one side and 5 liters on the other side. And this membrane isn't permeable to water, okay? And then they said you have 100 molecules of substance X. All right, and they were asking you, how does this work out?
Or the size of the mRNA that you have in the sequence.
Can we mute her? Okay, thank you. So they're trying to figure out, how do you figure out what the components are, or sorry, let me put it this way. This membrane isn't permeable to water, but it is permeable to substance X, okay? So you wanna know what are the percentages that's gonna go to each side. So what you need to do is calculate percentages. Of the total fluid, 2/3 of the fluid is on this side, 1/3 of the fluid is on this side. So they gave you a nice easy number to work this out, 100. So that would mean 66% or 66 molecules of substance X has to be on one side. Make that clear. 66 on one side and 33 on the other. It's percentage basis, right? Since that water can't cross, the substance X is going to go equally by percentage through the water. Okay. Hope that makes sense. So just what you do is you figure out the percentages of both, and the substance goes accordingly. Okay, it's distributed accordingly. All right. So what did we say? Solution A was hyperosmotic and isotonic, right? Because hyperosmotic, because we were dealing with the urea. Once the urea equilibrates, it was 300 on each side. So isotonic, excuse me. All right, so this kind of explains it. Osmolarity, we're dealing with everything. That includes the urea, okay? So A was hyperosmotic to B. It had more stuff in it. Tonicity is everything that doesn't cross. So you're thinking of charged particles. So A is isotonic to B. You will get a question or two on this. The math should be pretty straightforward. You can do it in your head. All right, this was in your notes for concentration. So the body stands at 0.9% saline. That's what our body's at. That's the salt content of our body. So whenever you get fluids in the hospital, that's what it is. You never give pure water. That'll make the cells shrink, right? Because if you put a bunch of pure water, that'll make the cells swell. Because if you have a bunch of pure water and a bunch of stuff in the cells, the water is going to want to go in the cells, make them larger, right? So you want to keep the body at normal saline or normal concentrations of salt. So this is a little bit much for you guys now, but just remember that normal body composition is 0.9% sodium chloride, okay? Sometimes they put dextrose in it. That's just sugar that if the patient is hypoglycemic. All right, let's try this one. Actually, somebody sent me this, and I think it was keyed wrong in the, but I'll show you the right answer. It was keyed wrong on one of the question banks.
For IV fluids, I don't think we got a single question over IV fluids, especially in term 1. Maybe 1, but the biggest concept is to understand osmolarity, tonicity, iso, hypo, and hyper. So don't stress out too much about IV fluids. Brady, do you remember anything about IV fluids in FTM1?
I don't, but I think Kishore mentioned that they did on their exam. Kishore's a term below us. He's term 4.
But was that more term 2? Was that more
I
term
can't recall. Yeah, I wouldn't stress that stuff. Just know the body is normally at 0.9% salt. Yeah, you don't need to memorize all those. I don't know them off the top of my head with lactated ringers and stuff. You don't need to know that.
Yeah, no. I know mannitol and that's it.
All right, so what we're looking at here is, so we're talking about sodium, right? So remember these channels, when these channels open, the sodium is gonna rush in. So sodium and potassium. So what happens is that the sodium starts to go in, right? Until you hit this threshold, this electrical threshold, probably at like -50, right? And at that point, all of the channels open up and then you get a flood of sodium into the cell. Okay, and then at this point we get up to about +40, and at this point the sodium channels close and the potassium channels open, and the potassium is going to rush out of the cell. Okay, so you get this rush of potassium out of the cell. So the highest sodium conductance will be at B, and the highest potassium conductance will be at C. Okay, this gets much more complicated when you start to do cardiac and you're looking at different, you have calcium involved, and there's all kind of different types of channels. But for right now, this is all you really need to know. The fact that we're having this intracellular flux of sodium into the cell going in, and then you get this conductance of potassium rushing out of the cell to get back to baseline. Okay, so this is the whole idea. Like, this is the way the body signals that it wants something to happen. It wants the muscle to move. It wants the heart to beat. You just want this little tap, right? This little impulse. Okay, you don't want it to be prolonged. You don't need it to be exacerbated or anything. You just kind of want a little jolt. So that's the whole idea of doing this. So it's just as important to get this jolt as it is to turn it off, right? You just want this little action potential. So what we can look at is some of the complications, like if you're not at the resting membrane potential you need to be, and I'll talk about that in just a second. I think there's another question coming up. All right, so you can see that here, and once you hit that
Brady,
threshold,
we have a lot of questions in the chat about that one.
Okay. Marked as the highest, still be B. So technically, okay, think about, well, B would have a higher conductance than the peak, okay? And the point is that there are more particles crossing over at B than there is here, okay? At this point, some of the channels are being closed, but imagine it like this. Let's say we left these channels open and we had conductance and it went all the way to 0. Okay, so we left all the channels open and we got to the point where nothing was crossing, it was equilibrium. So at this point, when it's almost 0, you don't have a high flux compared to right here. Like the point right here where the channels start to open, you have the biggest differential, with the most particles on one side compared to particles on the other side. So the flux is going to be faster. There's going to be more particles crossing. As you approach 0, it gets less, right? So what I'm saying is, if you look at it like this, right? And I guess this is a good point. We could talk about driving force. Let's say we had our channel right here, our gate open, and you had 1,000 particles on this side and say 5 on this side. This is going to be a strong conductance. This is a strong driving force, okay? You have 1,000 on one side versus 5. Now, if we compare that to say 7 on this side and 5 on this side, this would be a very small driving force. What is driving force, right? We're just talking about the electrical conductance that we're getting. These are ions that cross. If ions are crossing, that would indicate that you're making electricity, right? That's the whole premise of electricity. So as you can see, these arrows indicate the strength of the driving force. Now, you also have to take in the component that we sit at -60. That's our resting membrane potential. So that's our starting line. So from this point, this is going to have a higher conductance than this, correct? Now, if we looked at this curve, so we did something like this, and we reached threshold, we came up and we came back down. At this point, at point B, we still have more stuff on this side than we do on this side, right? So this arrow is going to be larger than, say, at point C. So at point C, and we looked at it, X and Y, this arrow would be smaller because there are less, you're closer to equilibrium. Okay, so the further you go up the line, the further you go to reaching zero or equilibrium, the less the driving force, the less the less the drive or the electricity that's going to go across, because there's less particles as you get closer to equilibrium. I don't think they'll get into that complicated. They'll probably, if they do it, they'll do it just like this. Okay. All right, and then this kind of explains it here. And generally speaking, you should keep this in mind. You sit at -60, that's your resting membrane potential. It's very important. You sit at -60. If you deviate from that, you can get arrhythmias and heart problems and among other things. All right, try this one. I'll give you a little time for this.
I want to reiterate that any calculation they give you on the exam is going to be one that can be done in the typing it out in the notes section. They know you don't have a whiteboard. They know you don't have a way to write it out. And so they're not going to give you a question that requires you to write it out.
That's a good question right here. So conductance and driving force. Driving force is conductance, right? The component of driving force that we're talking about is electricity. That's what you're conducting. So yeah, there's a direct correlation to driving force and conductance. The larger the conductance, the larger the driving force. RT over F is just telling you the equilibrium potential. I think I took this from one of Dr. Bandelow's questions, but I thought it was a good teaching point. So that just means your equilibrium potential, which is the standard for sodium, right? Yes, okay. All right, let's take a look at this. So this is what happens. You're gonna take these numbers, and fair game, because you could do this in your head, right? Driving force. So the first thing you're gonna take is our membrane potential. Actually, let's do this. Let me go a slide forward just so I could show you this real quick. I don't think it's very important to know these numbers right here, where everything sits, but it is very important to know these purple numbers here. So if you notice these, particularly sodium and potassium, okay? Not so much these, but I would know them all anyway, but definitely no sodium and potassium. All right, let's go back. All right, so we're gonna take our membrane potential, which is -60. And if you were to double check these are standard values, right? These are what we would expect. Assume normal intracellular electrolytes, okay? Normal, normal, normal. So if you know that, they don't even have to tell you this, but they did. You would expect this to be normal, correct? So we sit at -60 minus, and we know that RT over F, with all of our values normal for sodium, it should be 60 as well. So they may not give you these normal values on the test. I imagine they give you the normal resting potential or membrane potential. They might throw this off a little bit, particularly with potassium, but I'll talk about that in a second. All right, so -60 minus 60 is a -120. The main thing I wanted to show y'all here is why are there no negative numbers here, right? The negative number correlates to whether it's an influx or an efflux. All right, so the trick is that people like is that opposites attract. So for this one, let's see, we have a negative driving force, right? -120. and we know sodium is a cation. So negatives attract, positive and negative. That means they're going to influx. It's a little trick people use. So yeah, so by saying 120 millivolts of influx, you're basically saying the same thing as a negative 120, okay? By defining it as influx, you can correlate that to a negative number. So they may put that on a test and you may be like, I calculated negative 120. Well, you have to determine whether it's influx or efflux. Now, I will say, you should know that little trick, or you should know this table, however you need to know it, but opposites attract. I will say this, I've never seen a question where they went outside of the norm, meaning that potassium is always going to leave the cell, right? It's the one thing that's highly concentrated intracellularly. Sodium chloride and calcium is always going to go into the cell. So if you're running out of time or anything, just think about it like that. We're talking about sodium. Under normal conditions, you would expect sodium to go into the cell. Okay, if they were talking about potassium, it'd probably be an efflux. Okay, I haven't seen any questions. I'm not saying it couldn't happen. I still would know this little table, but if it came down to it, I would at least use that to check yourself. All right, so know these numbers. Now, what does this mean clinically, right? So as it stands, potassium being negative 83 is very close to the negative 60 where we sit at our resting membrane potential. Okay, what does that mean? That means potassium, it matters, right? It matters a lot because it is potassium, the intracellular potassium, that's holding our membrane at negative 60. If all we had was potassium, we would sit at negative 83, okay? But because we have those other channels, particularly sodium channels, it does bring it up slightly. But we are much closer to the equilibrium of potassium than sodium, right? So what this means clinically is if you have differences in your potassium, that's going to, if you have problems with your potassium away from the norm, it's going to shift your resting membrane potential significantly. Okay, so what does that mean? So if we were normally at negative 60 and we had our little graph, right? That's perfect. We're giving the body a little impulse. We're telling the muscle to twitch. We're telling the heart to beat, right? So, well, let me preface with this real quick. You always measure, when you take lab values, the extracellular fluid. Okay, you can't really measure what's inside the cell. So whenever they say, sorry, let's see, let's take this for example. Let's say the patient is hyperkalemic, right? Meaning there's a lot of potassium. What they're measuring is the potassium outside of the cell. Okay, they're saying the patient is hyperkalemic. So what does this mean for our driving force? Okay, so whereas we had a strong driving force, because there's so much outside, let's say there's just arbitrary numbers, 100 outside and 80 in, or sorry, 100 inside and 80 outside. Okay, we really messed up. We have a weak driving force now because there's not a lot that can cross. Let's say before it was maybe 100 inside and 20 outside. So a strong driving force. So because we have so much potassium outside of the cell, we messed our driving force up. So what's going to happen if we have less of a potassium driving force? This resting membrane potential is going to go closer to 0. Okay, and I'm using arbitrary numbers just to prove a point here. So what happens if we went from negative 60 and now we're starting at negative 20, right? We're firing action potentials way too much, right? We're way too close to threshold at this point, and it's a problem. You start twitching, you have arrhythmias, right? Your heart beats too much because we're supposed to be able to start at negative 60, and instead we're starting way too close to equilibrium. Okay, now the opposite can be true too. If you have hypokalemia, it will pull your membrane potential even closer to negative 83, maybe pull it to negative 80, and then it will be even harder to fire an action potential. Okay, so this is a little bit much I just wanted to show you if they ask you anything about this, they will ask you why, what's the major component, that's potassium, and what could go wrong. And that is that if there's too much or too little potassium, we're moving away from our normal resting potential. And if we do that, we're either firing action potentials too much or it's too hard to fire them. Okay, we want to sit right at -60. So when we want an action potential to happen, it happens correctly. Okay, now I do this and I go a little above, I go a little far with the explanations just because I find if you understand these concepts, it'll help you in the long term. Okay, so that's the whole thing. If your sodium's off, it probably just means you're dehydrated. It doesn't really affect your resting membrane potential too much, but if your potassium's off, it's a huge problem. And that's why, because it has such a governing effect on where you sit with your resting membrane potential. Okay, cool. Now, yeah, so again, opposites attract. So you can use that to help with this. But again, like I said, if they talk about potassium, it's probably going to be an efflux. If they talk about anything else, it'll probably be an influx. Okay. All right, let's go through some embryology. And I know I'm going fast. It's just because unfortunately we would have loved to do this, not the day before your exam, but our schedule, and we do reviews for all the other terms. This was the only time we could do it. And I know you guys need to go study. So again, this will be recorded if y'all want to go back and look at it. So a question we always get is, what in the world is embryology? I swear it's made up. Somebody just like fictional. I don't know what they're even talking about half the time. The main thing to key in on is that what are the complications if embryologically something goes wrong, right? And that's what they test on. They don't necessarily test on the normal process, what happens at these different stages. They say, this patient presents with, syndactyly, where their digits are together. And they're like, well, what happened wrong during embryologically that caused it to be like this? And this will be a common theme as you go through. Any of these embryology lectures, they're going to focus on the clinical problems and they want to know what actually went wrong. Okay, now in regards to this, this is very important. For pregnancy tests, the first thing you can always check is the beta HCG. That's the urinary pregnancy test, and that is secreted by the syncytial trophoblast. Okay, for right now, that's all you need to know. You'll get into more of that in term 2. Again, if you could draw this out, more power to you. But this is not something, you'll talk about a little of this as you go. We have a running joke that if you don't know the answer, it's probably neural crest cells, just because they love to test on this. And there's a lot of pathology that happens during development that can affect these neural crest cells. So just a general understanding of this, if you learn it now and remember it, this is a common thing that comes up. But I wouldn't spend too much time on this, just maybe these, the neural crest cells and some of these primitive cell structures. All right, try this.
Hey guys, sorry, I'm trying to get through questions that are directed at me. You can also direct them at everyone if you don't necessarily need Brady or myself to answer your question directly. You might get an answer faster. I'm trying to scroll through.
All right, so what we're looking at here is actually a hemidesmosome. Hemi meaning half, right? So you could see that it's attached to this basement membrane here, and you have these projections. What are these projections? What's the protein component? Anybody know? Need to know these. Starts with an I. Integrins, right? Did somebody put it? Yeah, they put it in the chat. Cool. Yeah, so that's what that is a component. You need to know the components of all the different you need to know the protein components of these different structures. Okay, so this is a hemidesmosome. Fair game. They could put this electron micrograph on the exam for sure. All right, so this is the clinical correlates for this hemidesmosome. These are problems at the basement membrane. So the patients can develop, if they have a problem with hemidesmosomes, they could develop bullous pemphigoid. So these blisters that form are like this. The way you can keep this in mind, bullous sounds like below, and you know the hemidesmosomes are below, right? So they can say these blisters are up and down, sort of like this, and they're very hard to pop. They're not easily popped. And that's because these desmosomes on the outside, they're working just fine. It's the hemidesmosomes that's the problem. So you do get blister formation, but it's not necessarily, they're not easy to pop. Now, the contrast here is in pemphigus vulgaris, you also get blisters, but these are very wide-based blisters like this. And the problem is here on these desmosomes, right? Desmosomes right here, you can see. So these are actually very easy to pop. So the desmosomes are going to connect cell to cell, right? So that's why these are easy to pop versus hemidesmosomes, bullous pemphigoid that are on the bottom, okay? So that's how you remember that. Yeah, and when they give you electron micrographs, they're always in order, meaning that the zonula occludens, or what is it called, macula? No, zonula occludens up top, then the zonula adherens, then the desmosomes. You can have gap junctions intermixed, and then you have the hemidesmosomes. Again, you need to know these protein components that are there. Guess I'm nerdy, but I tell you how I remember this. I feel like the zonula occludens are like glue, right? They're glued the cells together, so fluid and stuff can't pass through. The zonula adherens are like a tie wrap. They kind of hold the cell together from separating. The desmosomes are more like a spot weld. They're really strong. Remember that in contrast to hemidesmosomes, they have these protein structures that come off of both sides, okay? Right? So they're like a spot weld. They're really strong, these little spots. Also, and then gap junctions, remember they're connected by these connexons. So what these are like these little ball thingies, right, that are around, and they will allow fluid to go through here, through the middle. So these connexons kind of expand and they allow fluid to go through down the concentration gradient, okay? So this way for cells to communicate. And then of course the hemidesmosomes are at the bottom and they just have a single-sided projection. The other side is attached to the basement membrane. Okay, so this is actually pulled out of first aid. So you can kind of see how they approach the material. And again, that's where I got this little below thing, bullous pemphigoid. All right, for whatever reason, I can never remember these, but go ahead and try these. I always have to look these up. Right, so sebaceous glands are holocrine, right? Yes, and sweat glands are merocrine. Apocrine is like pheromones and stuff, which they don't really talk about. So if they ask you anything, it'll be holocrine. Remember, these sebaceous glands are at the base of hair follicles, typically. So like pus forms there, the sebaceous glands. And then again, merocrine is going to be your normal sweat gland. So this is the picture that they use. So just make sure you that holocrines like these larger secretory products that are released, like sebaceous gland or sebum, and then the merocrine are here, and this is like membrane bound vesicles, so like sweat. Okay, then you could talk about how it's actually distributed. Endocrine hormones are secreted directly into the blood, where exocrine is usually through ducts, and then how they're signaled. Paracrine meaning next to, so it transfers. Next to autocrine is self-signaling. Okay, so just keep this in mind, mostly holocrine and merocrine. All right, let's do some genetics. Try this one. So it's going to be very important to understand, what are we talking about, the sense strand versus the template strand, RNA versus DNA. Remember, I did this on purpose. I didn't put 5' to 3' on any of these answers. You always read them 5' to 3', okay? Right, you read left to right, 5' to 3' always. So make sure you keep that in mind, because a common mistake made is that people forget to flip it to 5' to 3'. All right, so let's take a look at this. So since strand, that's our original strand, we have to make the complementary strand to it. So again, I wrote this in the correct orientation, but if you were to do it, you know, it would be T, T, A, A, G, C, G, C. Okay, but then I wrote it in the correct orientation, 5' to 3'. So now we have our complementary strand, AKA our template strand. So from this template, we go down here, we take our template and we make RNA. So, right, it has to be complementary. So we do like this, right? It all matches up. We change our T's to U's, and then the answer has to be written 5' to 3'. Okay? So we're writing from this side to this side. Antisense is template is complementary strand, correct? Yep. So sense complementary is antisense or template strand. So just keep in mind, don't get it flipped. You always write 5' to 3'. Okay. It just takes practice. Once you do 2 or 3 of these, you got it. All right, try this one. All right, so if we have, I think I was drawing out, yes. So we know we're talking about both strands, right? So we know if you have 20% C's, you have to have 20% G's because they bind together, right? So this would equal 40% of our total amino acids, right? Not amino acids, but bases, okay? So 40% here. That means our A's plus our T's has to be the other 60%. We know they're split evenly, so it's got to be 30 and 30. So we switch our T's to U's for RNA, and you get 30%. You could check yourself using A's have to be 60 plus the other 40% is there. 20 and 20 is 40. That's 100%. All right. So these are easy questions on the exam. Make sure you do your math correct. So double check yourself. All right, try this one. All right, so this is actually a common thing in treatment. So one of the problems, well, the big problem with cancer is you can't turn it off. These cells are replicating infinitely, and that's how cancer forms. So what if we could go about upregulating a tumor suppressor gene, right? These tumor suppressor genes will tell the cell cycle to stop, right? What if we could upregulate one to help to make that tumor stop growing, right? So we're talking about euchromatin here, right? Not hetero, euchromatin, right? Meaning we want it to be translated. We want this tumor suppressor gene to be made in abundance so we could kind of counteract this tumor formation, okay? So what we're gonna do to make euchromatin is we're gonna have demethylation and histone acetylation, okay? So let's break this down real quick. Let's look at heterochromatin, okay? If I put a bunch of methyl groups all over this DNA, do you think it'll be easy to replicate it and transcribe it? No, you have all these bulky methyl groups on there. So if you do that, you're gonna end up silencing it, because you can't, like the transcription factors can't bind. So because you put a bunch of methyl groups. Okay. So also, if we're looking at heterochromatin, remember these histones that are formed, right? They're typically positively charged, but if you acetylate it, if you acetylate it, you take the charge off of it. Okay, so methylation, I'm sorry. Methylation and deacetylation, sorry. If you deacetylate it, you're taking the charge off of it. Okay, so remember, DNA is negatively charged. This histone should be positively charged so it could bind. But if you deacetylate it, this is not charged. This histone is no longer charged, so it's not going to bind the DNA. If it doesn't bind the DNA is free to be transcribed. Okay, so we can look at this in the opposite way too. So let's say these histones are acetylated. The histone is acetylated. That means it has a positive charge. Okay, if the histone has a positively charged, it's going to bind to the negatively charged DNA. If it's all wound up, the transcription factors can't bind. Okay, so we're talking about euchromatin here. Also, if you demethylate it, that means there's not a bunch of bulky methyl groups on our DNA. So hold on. Positive. Sorry. Okay. I think let me start over. Sorry, I think I may have said that incorrectly. So okay. So euchromatin has to be demethylated. Sorry about that, and acetylated. Okay, so by being demethylated, the transcription factors can bind. If the histones are acetylated, that actually means that it has no charge on it. I said that backwards, I apologize. So if it's acetylated, you actually took the positive charge off of the histone. If there's no positively charged, then the DNA, then it can't bind the DNA, and the DNA is free to be transcribed. Okay, so that's the idea. You want the DNA to be open. You don't want it to be bound to histones. You don't want a bunch of methyl groups. So the opposite is true. So for hetero, you want methylation, right? You want those bulky methyl groups plus deacetylation. So if it's methylated, there's a bunch of methyl groups on there, so it cannot, the transcription factors can't bind. And if it is deacetylated, the histone is deacetylated, then it actually has a positive charge on it. Okay, I think that's what I said incorrectly. If it's deacetylated, it has a positive charge. That means it can bind to the negatively charged DNA. So it's all wound up. Okay, I apologize for that. All right, so you can see here, these transcription factors have to, bind. If there's methyl groups there, then they can't bind. And then acetylation, you can see here, if it's acetylated, it doesn't have the positive charge, so it can be transcribed, it's euchromatin. If it's deacetylated, you see it has a positive charge, that means it'll bind to the negatively charged DNA. Now, a quick way of doing this, if you just remember the methylation part, then you're fine, because you always have to have a DE on one of them, right? So if you remember that DNA methylation puts a bunch of bulky groups on there, so you can't transcribe it, so it's silenced. Then you also know that you have to have a DE, so histone deacetylation correlates with heterochromatin. And the contrast is true. If you demethylate it, there's room for the transcription factors to bind. Since you have a DE on one, acetylate on the other. I think someone said acetylation correlates to active, if that works for you too. But just understand, you need to know why, right? You need to know that that acetylation will actually remove that, that positively charged on the histone. And the reason it's active is because the DNA won't bind the histone, okay? All right, try this one. Yes, P53 is at the G1S checkpoint, so is RB. Okay, so very straightforward. These are cell cycle regulators. These are checkpoints, meaning that if RB or P53 is activated, it's like a stop sign. If it's activated, then it will tell the cell to stop replicating. Okay, P53 is actually a culprit in almost 50% of tumors. Of cancers out there. So if P53 is mutated, it can't put the stop sign. It can't be activated. It can't stop the cell from replicating. Okay, so that's a common problem in cancer formation. But yes, these are all cell cycle regulators, and you can see that here. This G1. Yeah, I'm going to show y'all a slide coming up about what y'all actually need to know all of these. Just in case it's one of those silly things you have to memorize. So yeah, RB and P53 are at that G1S checkpoint. Right here, star this down here. You need to know which kinases and cyclins go with each checkpoint. Yeah, unfortunately, I don't know that there's really a good way to do it, except you don't need to know these. They told y'all you don't? Oh. Okay, if they took it out, then so be it. They made us learn these, but yeah. Apparently they took it out. Okay, never mind then. All right, try this. Yeah, definitely still no P53. G1S checkpoint, you definitely need to know that when it's activated, it will stop the cell cycle. So if it's mutated, it cannot be activated. The cell will keep replicating. That by definition is cancer or tumor formation. All right, so first step here, what is cystic fibrosis? It's autosomal recessive. Now, a key thing you need to know is that unless they tell you that the child of interest is still in utero, hasn't been born yet, you can assume that this child does not actually have cystic fibrosis, okay? So this is actually that 2/3 rule. So if we make our Punnett square and since the other child has cystic fibrosis, you would assume both parents have to be carriers, right? They don't tell us that one of the parents has it, so they're both carriers. So as this works out, it would look something like this. Now, they said one of the children has it, right? Now, you want to know if the other child has it. So unless they tell you the child hasn't been born yet, you can assume this child does not have cystic fibrosis. This is the 2/3 rule, meaning that there is a 2/3, 2 of 3, 2/3 chance that this child is a carrier, okay? So very important point, unless the child hasn't been born yet, you could assume when they bring her into the office that the child doesn't have cystic fibrosis. They just want to know if she's actually a carrier, he or she. Okay, so yeah, so 67%. Is the notes tool in ExamSoft Punnett square friendly? No, it is not. Do it in your head. What is the chance the other child is affected? Right, so that's the child we were interested in. So if the child's born, it would be the 2/3 rule. What I mean by not born yet, right? So if the child's still in utero, the parents don't know. The child may actually have cystic fibrosis. So it's still a 50-50 chance. All right, but if the child's born and you look at the child and the child doesn't have cystic fibrosis, you could take out that possibility. So it's a 2/3 rule. I don't understand. Punnett square says, what is the chance of the child being a carrier with, okay, right, let me do it. I'll do it one more time. So what we're looking at here, so let's say you have a 7-year-old child, female, who has cystic fibrosis. Okay. Now she also has a 5-year-old little sister, and you want to know, is this child a carrier? Okay. We know this child has cystic fibrosis. That tells us that both parents are carriers. They have to be. That's the only way the child can get cystic fibrosis. Okay. Now, this child is 5 years old. She does, like, you'd know by now if she has cystic fibrosis. All right. So we're telling you, when she goes in at 5 years old, we're saying she doesn't have cystic fibrosis, but we want to know if she's a carrier. Okay. So when we do our Punnett square like this, we do it like that, we can automatically say, when she walks into the office, that this is out of the question. No chance she has the disease. Okay, so that means there's a 2/3 chance, 2 out of 3 boxes, chance that she's a carrier. Okay, 2/3 chance. She definitely doesn't have the disease because she's 5 years old, and we know by now. Now, what if she wasn't born yet? Well, we can't definitively say unless we did genetic testing in utero. They'd have to tell you that. If she's not born yet, then we're assuming that they don't know definitively if she actually could have cystic fibrosis. So there's a 50% chance she's a carrier. There's a 25% she's autosomal normal, and there would be a 25% chance she actually has cystic fibrosis. The point is, if she's 5 years old or whatever, if she's born, you do make the assumption that she doesn't actually have the disease. Okay, hope that made sense. All right, and you can see that here. So when we're looking at this, yeah, if we're looking at this, if we know the child's born and doesn't have it, we can take this box out, so it's a 2/3 chance. If you're one of these people that likes these little diagrams like this is a definitive way where you can diagnose different diseases like that, whether they're X-linked, autosomal recessive, or whatnot. All right, y'all don't have Dr. Sobring. Sadly, he left this term. He was one of our favorite teachers. He taught us genetics, but anyway, I think Dr. Mpadya is teaching y'all, and she's great too. So there are 2 gain-of-function mutations you have to be aware of, and they are achondroplasia. Does anybody know the other one off the top of your head? Huntington's, exactly. Yes, these are the 2 you need to know. So gain-of-function mutation means it gains some novel property, right? Huntington's, you get these they're called choreiform movements, or these flailing of your arms, these involuntary movements. So it's attainment of this novel function, this new thing, right? Achondroplasia, it could also, this gain of function could also be too much of a normal thing, like you gained strength to this normality, which means, and in achondroplasia, that with achondroplasia, it closes the growth plates too soon, right? So too much of this factor, this fibroblast, FGF, yeah, fibroblast growth factor actually closes the growth plates too soon. Oh yeah, man of ham, chap gets cash, and we can't say the dirty one for X-linked recessive. Y'all probably heard that one. Y'all can search it on Google. Sorry, I was looking at the chat. So yeah, the mnemonics for autosomal dominant, to remember them, is man of ham. I think I have it later on in the slides. Autosomal recessive equals chap gets cash. So you can look these up. If you just search them on Google, it'll tell you what everything means. The E right here, it stands for enzymatic. What does that mean? So typically, this is not a steadfast rule, but typically autosomal dominant problems tend to be structural, okay? Like problems in bone formation. Typically, autosomal recessive problems tend to be enzymatic problems, like phenylketonuria or PKU, right? Problem with the actual enzyme. It's not steadfast, there are exceptions. And there is an X-linked recessive one. We're not gonna say it, but you can look it up on the internet. You won't forget it, I promise. All right, so let's look at these. Lindsey and I are actually going back through these right now with a million other drugs in term 5, but You need to have a good definition. Right now, y'all are just touching on the drugs. So if you have a general definition of the mechanism of action, you should be good to go. Okay, so let's look at this. Cold sore, this is herpes simplex 1. Oh, it says that here. What is the mechanism of action? So it's a straightforward question. How does it work? So it actually uses the viral reverse transcriptase and then the host viral kinase to initiate termination. What's interesting about this is if a patient that takes this doesn't have herpes, nothing happens because the virus, the viral reverse transcriptase, has to activate the drug. So if you don't have the virus in your system, it doesn't do anything. Okay, so the virus actually initiates the metabolism of this drug to work. Now, what you'll see also, and sorry, it's a two-step process. So the virus goes first, and then you can actually use the host kinase next. That's too much for y'all to know right now. Just know that you need the virus to be present to to actually work. Otherwise, if a patient that doesn't have herpes and the virus isn't there, it just doesn't work. It doesn't incorporate into the DNA. Now, what is this big deal about the 3' OH? So what these drugs, let's take like adenosine, right? So right, so these drugs look like just like the 4 base pairs, right? So they designed them ATGC, right? But when you add these bases in normal circumstances, you have to have a 3' OH. Okay, so at the very end, you have to have an OH so that the next base can bind to it. Okay, you always have to have an OH there so the next base can bind. Now, what these drugs actually do is they look exactly the same, except they don't have an OH there. So when the next base comes to bind, it has nothing to hook onto. Okay, so that's the whole idea. If there's no OH there, they can't link up. And that's the point. So you end up getting, if it can't bind there, you end up getting chain termination. And as I mentioned with HSV, if you don't, you have to have, the virus has to be present for this to actually end up going into kit, because you need the viral kinase, which is, you'll learn about those later, but the viral kinase helps to activate this. Okay, so pretty cool way of designing a drug, right? Because if you don't have the virus in you, you kind of just pee it out. Okay, so I did put these here too. Zidovudine or AZT is used in H treatment. Again, they use the same concept of this 3' OH. Cytidine arabinase, I think, yeah, that's that steric hindrance. So it kind of like, steric hindrance means it kind of like tweaks the molecule a little bit. It shifts it so that the other molecule can't come and bind to it. You need to know these. Now, what's important here is that these are for eukaryotes. Right? Meaning they're used in cancer treatment, okay? You want to stop these cells from replicating. So you want to block the topoisomerases. DNA gyrase, this drug always comes up. Make sure you know this one. It comes up cumulatively too. You use ciprofloxacin. So DNA gyrase is basically just a topoisomerase. So you would use cipro for bacterial infection. Okay. So if you don't have topoisomerase, you can't undo all those supercoils, right? And if there's too much supercoils, the DNA just breaks up. All right, let's do this one.
Hey, Brady, there were some confusions about the drugs in the chat.
About the drugs in the chat. Okay. Let's see about these. I thought exactly what it was, a viral DNA polymers. No, well, no. So it mimics the base, right? So by doing that and not having the 3' OH, these definitions are straight from your notes. Okay, so if you know these, then you should be good. All right. So let's see, what are we doing? Splice donor site in intron 1. We're going to do this very systematically. So splice donor site. Donor acceptor. All right, so check this out. Steadfast rule here. You always cut from the first, you always cut from donor site to acceptor site. That's the only real rule you need to follow. So if we do this normally, we walk down from left to right, find our first donor site, we cut here, go to our first acceptor site, we cut here. So this piece got cut out. Okay, now we walk down, we're going to find our next first donor site right here, and our first acceptor site right here. So we're going to cut this out. Perfect, right? So now let's initiate some issues here. So what did it say? What are we cutting? Donor site. Okay, so we have a mutation here. We lost this donor site. What is the rule? You go from first donor site to first acceptor site. All right, so we're walking down. This is mutated, it can't work. Okay, so is the next one a donor site? No, it's an acceptor site. We can't do anything. We're going first donor to first acceptor. All right, keep walking down. We found our first donor. Now we'll keep walking to our first acceptor. So this got cut out. So this ends up looking like you kept E1, right? We couldn't cut this out. So I1 stayed, intron 1, E2 stayed, and then we cut out I2. So now we got E3. Okay, so that's how, that should be the answer. Sorry, I didn't let that, whoops. Don't know what happened there. Came up on my screen. Sorry, I'll do that again for you. Did that mess up the whole time, or did y'all see anything I drew? Okay, so let's just do it through here. So, so we have our first, we cut from introns. So donor to acceptor, donor to acceptor. Now, again, what we said was we have a mutation here. So what's the rule? We go donor to acceptor. So we're walking along. Nope, it's mutated, keep walking. Nope, that's not a donor site, keep walking. There's a donor site. All right, cut. Now we cut out our donor, now go to the first acceptor. There it is, cut. So all we're taking out in this sequence is intron 2. Okay, so let's try some other ones. Let's say we have a mutation at our acceptor site instead, okay? Now we'll have a mutation here at this acceptor site. All right, walk along, cut at our first donor site. We're walking, donor site, cut. Now we're going to our first acceptor site. Keep walking, keep going. Nope, it's mutated. Keep going. Nope, that's not an acceptor site. Keep going. There it is, cut here. So if that was the case, we would cut this whole section out. Okay, let's try this. What if we added one in there? Let's go donor, acceptor, donor, acceptor. Now we have a mutation where we put an extra acceptor site right here. Okay. Now let's walk along. We're walking, first donor site, cut. Now we cut at our first acceptor site. Keep going, we found one. Cut here. So this part will go out. Now we're going from first donor. Nope, that's an acceptor site. First donor there to next acceptor there. Cut this out. So in that case, exon 1 would be there. We would just have this little bit of extra intron 1 because we added this acceptor site in the intron. So the whole point is you just go from the first working donor to the first working acceptor every single time. Okay, if you do that, there's no way they could trip you up. All right, and you can see that here, these intron sequences typically at the 5' end, these donor sites are GU, the acceptor sites are AGs. But I think this question is as hard as they're gonna make it for you guys. So just practice with these, first donor, first acceptor, that's it. All right, that's what I wrote here. Always go first donor to first acceptor. If it's mutated, go to the next one. We got a hand raised, go for it. You have a question?
Sorry,
Okay.
I prevented people from unmuting themselves for a while because people were getting unmuted. So I just reversed that. So
Okay.
you can unmute yourself and ask your question now. Sorry.
Oh yeah, thank you. So in the notes they were talking about cryptic splice sites. So that would be like within an exon. Do we treat that the same way as treating as a donor or acceptor site?
You mean like if they added a donor or acceptor in an exon?
Like is that what a cryptic splice site is? I saw that. Okay.
I'm not familiar with that terminology. Usually they would call it donor or acceptor. Cryptic meaning like, I'm not exactly sure.
With beta or B thalassemia, they called it the cryptic splice site.
For a mutation?
Yes, it was like cut in the middle of an exon, so I made it shorter. And would I approach it the same way?
Yeah, so let's assume like we could do that here. So let's assume we put this cryptic site, if that's what they're referring to it, but they'd have to define it as a donor or acceptor. Okay, so if we put an extra donor site there, whoops, let's see. Right, we still cut, sorry, hold on 1 second. You would still cut donor to acceptor. So we're walking, cut at first donor, right? We keep walking, there's another donor, we don't care because we're going donor to acceptor. So as you can see here, we actually ended up cutting a little bit piece out of the exon. I'm not familiar with them calling cryptic, but regardless of anything, they'd have to define it as a donor or acceptor, so you could tell the difference. Because like, put it this way, what if you put an acceptor site right here, right up here? It doesn't matter. We're going first donor to first acceptor, so we don't care about that. We're going donor, right, to acceptor, right? So we cut this out.
So if they define one, like the donor site is in the middle of an exon, we will still go to where we know the acceptor site is, correct?
Yes, yes, okay. Yep. So you can never go donor to donor, right? You can never go acceptor to acceptor. It has to be this donor to the next acceptor. That's the best rule I could give you to help navigate this. It's never failed me. So, all right, we have another question. Christine.
I could just explain that the whole cryptic thing is just when we create weak splice sites. So like those two terms can kind of be considered interchangeable, because we know that the consensus sequences in those donor sites, like the donor will always be, well, what is it, AG, I think? Or sorry, AG and GU.
Yeah, right here.
GU donor and AG acceptor. So we know that in consensus sequence wise, those two will always really be there. But there are other areas in the DNA where like the base pair right before it can be like half the time it's G, half the time it's something else. You know what I mean? So when we have those weird consensus sequences, we create weak splice sites. So with a bunch of mutations, you can have ones that end up acting like a splice site donor or a splice site acceptor, and that's where we get the word cryptic from. So I just wanted to like kind of clear that up. Anybody didn't remember that.
Cool, thank you. I appreciate that. So yes, okay. So then the same rules apply. If they put it in there, weak or not, they would have to assume it's going to act accordingly. So follow the same rules. And these are pretty much all of the variations you can have, but all of these follow the same principle. All right, everybody loves meiosis and mitosis. So let's go look at this one. Right, yeah, so this is, if we're looking at the spermatozoa, this is that final product, right? The final product that the sperm is going to be at prior to fertilizing the egg, right? So you would expect it 23, 1 in, right? So, typically we have this 46, right? 1 from mom, we'll give the other color. 1 from dad, so it's 46 and it's 2 in. But when we get down to the sperm and we're ready, these germ cells are ready to replicate, we have to get 23, 1 in, 1 from dad, and then the other 23, 1 in from mom, right? And then that makes a diploid fertilized egg, right? All right, so here's the thing. We're gonna look at this briefly. I know this is a difficult concept. This is the best slide you can use for this. So what we have, so if you look here, the N's going to correlate to different copies. Okay, so different copies. The D is going to correlate to strands. Okay, that's the best terminology I could use because it's easy to count that way. So typically you have 46 to N. Okay, now at this phase, we're ready to replicate. Well, we did replicate. We're saying we're going to undergo meiosis, right? So at this point, we've replicated moms, we've replicated dads. So we have 2 different types, but 4 total copies. All right, meiosis 1, split these up. Okay, so now in each different gamete, or cell, they're not gametes yet, but they're cells, you have 1 type in each, right? So 1 in, but 2 strands in each, okay? Now we're gonna undergo meiosis 2, where we get down to our 23 in, right? 1 type and 1 strand. So at this point, now the sperm could come along and now it could be fertilized. So you get 2 in, 2 types and 2 copies. That's our diploid. And then now you have the zygote and you got a baby. All right, now problems can occur. And this is what we talk about when we get our trisomies, like Down syndrome and stuff. So if you have a problem, non-disjunction, non-separation, right? They're joined, they can't disjoin, okay? So we see here, this happened at meiosis 1. As you can see, they were supposed to split and they did. So both are in one side. So if you go through the normal process, I understand the problem happened during meiosis 1. That's how they split like this. So now when they split up, you're going to have 2 in this side, in this gamete, and 2 in this side, and then empty gametes here. So inevitably, if either one of these gets fertilized, you're going to end up with the trisomy. Okay. Now the opposite, not opposite, but it can also happen in non-disjunction at meiosis 2. So we see the normal separation here, and then they didn't disjoin, right? So you could see 2 copies here, an empty gamete, and these are normal. So we see here that if this one was to be fertilized, you can see that you had a trisomy here. Now, this is not a steadfast rule, but this is a little trick that someone told me that I remembered a long time ago. Now, skip the first X. This is just a trick. Skip the first X. After that, if you have 1 of each, the problem happened in non-disjunction 1. Okay, non-disjunction 2, skip the first X. If you have 2 copies of each, it happened in non-disjunction 2. Technically, Turner syndrome can happen in either. There are some crossovers. If I had to bet money, I would say that they would ask you about Klinefelters, okay? Fairly common. These are not very common. We don't really talk about them too much, but we do talk about Klinefelters. So, yeah, so what we see here is you can see it's a male, but this male is going to have feminine characteristics, okay? Maybe gland hyperplasia, breast development stuff, but it's still a man. And they tend to be infertile as well. Okay, but let me ask you this. Did the problem, and somebody could say out loud how they feel, we could discuss this. Did the problem happen with mom or with dad? Anybody?
No.
Mom,
Mom.
right? And why is that?
Well, because you the Y, sorry for the police sirens.
No,
The
you're good.
Y is from dad, so then the X has to be from mom.
Exactly. Yeah, that's exactly right. So the Y came from dad. So you know that wasn't the problem. It was a problem. They didn't disjoin. You had non-disjunction in mom's gamete. Okay, so that's why you ended up with two X's. It couldn't have been dad's because dad gave the Y. Now, if it was X, it was. I'm sorry. That's right here. If it was XYY, where'd the problem happen? With dad, right? Because dad had to give the Y. Mom doesn't have a Y. With this, you can't tell because it could have been from mom or dad with either X. And then Turner syndrome, you can't tell either because
XYY is not viable, correct?
it is actually. Yeah, I think I looked that up. I'm pretty sure it is. It's not common, but don't quote me on that, but I'm pretty sure it is. So how do the little girls present with Turner syndrome? They talk about their very short stature, they have webbed necks, and they're also infertile. They have what's called coarctation of the aorta. It's a common thing. You'll learn about that later as well. I'm pretty sure it is the XYY, but maybe I could be wrong. So we'll have to double check that. All right, so that's just a little trick. Don't get too bogged down with the meiosis stuff. It's not, I wouldn't call it high yield, but it's good to know. Just keep in mind that if it's Klinefelter's, it probably happened at that first non-disjunction on mom's side. We got a hand raised. Question?
Yeah, I have a question on the last picture. So they showed like the blue chromosome coming from dad, but is the green fertilization also from dad? So technically dad has two contributions?
Okay, so no, all of this blue and red is from mom, right? The green is the fertilizer. That's where the sperm came in, right? So this is now you could say this inside mom, this is from her mom and her dad, but this is all from mom. So they get down and this is all mom, and then the egg, the sperm, the green is from dad, the new dad to make the baby, right? Okay, have y'all had a question? We good?
Yeah, so that means that in like the first cell, it's contribution from both grandma and grandpa.
Correct.
Until
yes.
it goes down to dad's contribution.
Yes, and the way this is drawn is just show it. Like you could do the same thing with dad's sperm. Like you could do the same thing just from dad's side. It's just drawn this way to show that dad comes in with the sperm. But you could have two green lines at this too if you did it from dad from the beginning.
Got it. Okay, thank you.
Okay, I don't know if y'all had Dr. Trotz yet. This is one of her slides. We love her. We'll take a little break, I think. Oh gosh, we got a lot more. Okay, we'll take a couple minute break and then we'll look at some of the pedigrees as well. Let's do 5 minutes.
Brady, we had a request to go back over conductance. If you want to do that now versus at the end.
The conductance,
Yeah.
like driving force?
Conductance of ions. So there was a question about combination of conductance of ions leading to a 0 millivolt membrane potential and how you would be able to figure out that which combination would add up to a 0 millivolt.
So the whole goal of the cell is never to get to equilibrium. Like you want to, and those sodium potassium ATPase pumps keep the gradient keep the gradient there so that you can always have ionic flow. But by definition, if you don't have flow across the membrane, if you have 10 over here and 10 over here, like there's no crossing over. So it's 0 millivolts, right? There's no electrical charge. So you have 0 conductance. Now, the more particles you have on this side compared to particles on the other side, the higher the driving force, the higher the millivolts, the higher the conductance. Okay, so conductance and driving force, it's all talking about ion flow, which by definition is electricity. All right, let's take a few minute break. All right. If y'all are ready, we'll go through some of this genetic stuff. Okay, So some of the characteristics, like I mentioned earlier, autosomal dominant tends to be structural problems. Look at like osteogenesis imperfecta, bone problem. You have a lot of fractures in the bone because the collagen can't form correctly. Whereas some of the autosomal recessive problems are enzymatic problems. So problems like phenylketonuria, PKU, phenylketonuria, and stuff like that. So, and then of course there's the X-linked problems, but we'll go through these independently. So what you see in autosomal dominant, you only need one mutation from mom or dad to actually have the disease. Therefore, you see what's called this vertical transmission. Every subsequent generation is gonna have the disease. Since it's autosomal and not X-linked, it's a 50-50 distribution. There's no sex inheritance there. So it's equally distributed among guys and girls, okay? Recessive, you see skipping of generations. That's because there's a 1/4 chance, right? So every time you have a child, there's a 1/4 chance they will get the disease. So you see this horizontal transmission, but you don't necessarily see it in every generation, okay? Keep in mind that it's the same thing with autosomal dominant. You can have 5 kids that just happen to have the disease. The 6th kid, it's still a coin flip. Every subsequent birth is its own independent variable, okay? So it's 50-50 chance for autosomal dominant. Autosomal recessive tends to be 1/4. And then of course, if you have the disease in one allele, you are a carrier. Now, X-linked recessive, we see that it tends to go that the females will be carriers if they get it from dad. So females, there's no male to male transmission, right? You have to have it go from male to female since it's X-linked. And so you see skipping of generations, and you see a predominance in males for X-linked recessive. Why is that? Because they only have one X. So if that X is mutated, by definition, they have to have the disease. Okay, mitochondrial inheritance from a female mother, right? From a female, all children are infected. Why is that? Because you get all your mitochondrial genes from your mom, right? Another one of these graphs, you can see if you like these, this will help you diagnose the different patterns. Here it is, man of Ham. So as you can see, the vast majority of these, besides this one, are structural, okay? So, but this is a good way of remembering it, man of Ham. Chap gets cast, as I said, enzymatic processes typically, that's what the E's for. But for instance, cystic fibrosis is a structural problem. It's a membrane receptor, but most of these other ones are going to be enzymatic problems, okay? X-linked recessive, I'm not gonna tell you, but y'all can look it up and see the way to remember that. All right. And so there's some terminology. This is from first aid. Some of these things, it's very important to know the difference. So when we talk about variable expressivity, that just means that different patients will show different phenotypic traits, right? So some will get this characteristic, some will get this symptom. It'll be variable to it. Incomplete penetrance is an all or nothing thing. So whereas if your grandma had the disease and your mom didn't have she had the disease, but she showed no signs, no phenotypic signs for it, and then you got the disease from her and you showed signs, it's an incomplete penetrance. So the genotype, they actually do have the disease, but it's an all or nothing thing. It's like a light switch. They just didn't actually show any phenotypic signs that they had it. So whereas variable expressivity is a spectrum of how the disease is, incomplete penetrance is an all or nothing thing. The idea of anticipation, we use Huntington's as the typical example for that. So you get these trinucleotide repeats. For Huntington's, it's a CAG repeat, polyglutamate, because the CAG codes for glutamate. With anticipation, if say the father has 50 repeats, and then so the son's going to have more than that, say he has 60 repeats, by the definition of anticipation, he will get the child will get the disease sooner, okay? So, and that's because with each subsequent generation, you get more of these repeats, and the more repeats, the earlier the onset. Okay. This concept of dominant negative, you want to compare that to haploinsufficiency. So dominant negative means you're making normal proteins, or let's use proteins for example. You're making normal protein, but you're also making abnormal protein. So the abnormal protein is counteracting the normal protein. So like, for example, osteogenesis imperfecta, you're making normal collagen, but you're also making abnormal collagen. All right, you're making enough collagen, but half of it is defective, okay? So that has a negative effect on it. Whereas haploinsufficiency, all of the protein you're making is normal, you're just making less of it. You may make 70% of what you're supposed to have. Okay, so that's a big difference between those two. Locus heterogeneity means you can get the same disease, but there's, the same disease, but there is a mutation on different genes, okay? Polycystic kidney disease as an example, you can have it on different chromosomes, both leading to PKD. Allelic heterogeneity, it means that you can have mutations on the same gene that cause disease. Cystic fibrosis, there's tons of different mutations on the cystic fibrosis gene. Since they're on the same gene, they still cause cystic fibrosis. So locus is different genes, allelic is the same gene. Heteroplasmy just means there's a mutation in the mitochondrial DNA. Uniparental disomy is when we talk about imprinting, right? So we talk about Prader-Willi and Angelman's, and we have that coming up right now. So the idea that the concept of imprinting is a normal process, okay? The process of imprinting is silencing a gene. So what's supposed to happen under normal circumstances is you want to get one SNRPN active from dad and one UBE3A active from mom, which means you want to silence the opposite. So on mom's side, you want to silence the SNRPN, and on dad's side, you want to silence the UBE3A, okay? And this is what's supposed to happen normally. So you want one copy, one SNRPN from dad, one UBE3A from mom, everything else silenced, and you're good. Now, what if there are problems with it? Now, let's assume here that we had a mutation on dad's gene. What does this mean? That means we have no SNRPN, right? The mom's is doing what it's supposed to do. It's supposed to silence the SNRPN, but dad, it's not there. So we have a parental deletion, okay? And that leads to Prader-Willi syndrome. You could think of P for Prader as paternal. It's a paternal deletion. Now, what's interesting is that, let's say we had a uniparental disomy from mom. So sometimes in the cell, you get, you end up with a trisomy, sort of like this, and you go through this process called trisomy rescue, right? So the cell freaks out. It's like, there's 3 copies, I need to kick one out. And it'll kick one out randomly, right? So it'll actually, let's say it kicked out dad's, and we're left with 2 copies from mom. Now, the whole point here is that if it's a parental deletion or a uniparental disomy from mom, you still get Prader-Willi syndrome. There's still no SNRPN from dad, either way, right? Whether we have 2 copies from mom or or 1 copy from mom and an empty space, nothing from dad. The whole point is we still don't have an active SNRPN, okay? Now, the same thing can go on the opposite side for Angelman syndrome. And so this is, excuse me, let me go back. So this is what would happen if we had this uniparental disomy. So we have 2 copies from mom. Whole point is mom's copy is supposed to silence the SNRPN. It does it, so we have no active SNRPN, right? Okay, so it's the same thing. You still get Prader-Willi syndrome. Angelman's the same thing on the other side. Maternal deletion of UBE3A. So we don't, dad is methylating it, so it's silencing it like it's supposed to. But mom, we don't have that copy from mom. Now, you still get Angelman if you get 2 copies from dad, because the whole point is there's no active UBE3A, okay? So keep those separate. Very interesting that, with Prader-Willi syndrome, you get these overweight, hyperphagia, they eat a lot, children, whereas Angelman syndrome is, they call it, I don't know if this is politically correct anymore, but they call it like a happy puppet syndrome, right? They're very skinny, they have these outbursts, but they're very, being that it's just the same concept of this imprinting on, you know, similar genes, they produce such different phenotypic effects. And if you want to remember Angelman, the M for maternal problem. Okay, so Prader-Willi, the P is for paternal deletion, the man is for maternal deletion. Okay, just keep in mind that with the deletion versus the uniparental disomy, if you don't have the active copy, you're going to get the disease. All right, try this one. Oops. All right, so if we look at this, sickle cell we know is autosomal recessive, and this looks pretty autosomal recessive, right? Skipping generations. Okay, so obligate carriers. So let's draw this out. Let's see. So this mom has the disease. So she had to give a little a here, a little a here, and a little a here. All right, now we can also work backwards. We know if this kid has it and this kid has it, that means, and neither of these parents actually showed the disease, that means they both have to be carriers, right? Hey, hey. So 2, 1, 2, and 3, and 3, 1, and 2 should be the answer, right? Okay, yeah, autosomal recessive. Nope, it's autosomal recessive. Okay, that's how you do that. And try this one. There's no there's no turning point code. This is not a PLG. I just got a message. This is not a PLG. This is independent. We do this on our own. So this is not affiliated with school. All right, probability of 4-3 being homozygous. Don't get tripped up. We're saying big A, right? Homozygous, normal. 4-3, so 4, 1, 2, 3. All right. So we can definitively say they don't have the disease, right? So if we did our pedigree, they're not little a, right? Because they're not colored in over here. So the chances that they are homozygous normal, not a carrier, but homozygous normal, are 1 in 3, right? So 1/3 chance they're homozygous normal, and a 2/3 chance that they're carriers. So it should be 33%. Yeah. All right, try this one. Yes, if the question was asking for a carrier, it'd be 67, the 2/3 rule. All right, so let's look at this. What are the symptoms? Seizures, exhibits inappropriate outbursts of laughter. They don't put these in the questions just because, right? This is a very big diagnostic clue. It's very unique to the situation. So this little child has Angelman syndrome. So we talked about that before. Angelman syndrome is the process of imprinting. So we know Angelman's is a maternal deletion, meaning that there's no UBE3A exhibited. So that's why this child has that. All right, and then these are some other diseases that follow those patterns. All right, and just in case they talk about this germline mosaicism, we don't get into it too much, but it just means that some of the cells, the germ cells, have a mutation and some don't. This is how they classically write these questions, okay? They said a healthy man has two different children from different partners, okay? And both of the children have the disease from different moms, right? So, and the original dad doesn't have the disease. So classically, that's indicative that there's some sort of germline problem with dad, okay? So, but that's how they classically do this. Yeah, I mean, in the sense for this question, that's how I've seen these questions written. There's really no other way that I know of to go about it. All right, try this one. Right, so y'all are just starting to look at drugs. So right now, if you just have a solid definition, a mechanism of action for how these work, you should be good. So 50S, that's how it blocks this ribosomal translocation. That's how erythromycin works. And then I put the other drugs there as well. So again, if you know these definitions, you should be able to answer these. It should be pretty straightforward. And I would start the slide. This is from your notes. These are where I got these definitions from. So right now, this should be good for you guys. All right, try this one. Not super high yield at this point, but it was in your notes, so I thought I'd bring it up.
This was in our notes.
It was, okay, good. And what you see actually when endogenous insulin secretion, meaning your body's actually making it, it's attached to C-peptide. So the C-peptide breaks off. It lasts in your blood a little bit longer than insulin does, but it is a precursor, not a precursor, but it is a marker that insulin is being secreted in your body. Diabetics who take external insulin, exogenous insulin, there's no C-peptide. So that's how you can measure whether it's being made in your body or taking it externally. But yes, C-peptide is always attached to insulin. And you can see that here. Whoops. All right, prions. Try this one. This is mad cow disease, if y'all aren't familiar with it in cows. But humans can get it too. Good. So another one of those things, when you read questions, if you're stressed or if you're reading too fast, you miss the knot sometimes. But this is definitely a common test question. All right. Yes, the answer is that the prions, the infectious prions, have more beta pleated sheets. So definitely star this side. This is not normal prions, but if they become infectious, they have these beta pleated sheets. They just collect in your brain and cause a constellation of neurologic symptoms. All right, try this one. All right. So the idea of having an allosteric modulator means that it doesn't bind to the same site. It's non-competitive. So if the enzyme is blue here and it binds to this site, an allosteric modulator binds to a different site. By this allosteric modulator binding there, it changes the conformation of this pocket, making it more difficult for this enzyme to bind. Okay, but you can see because they have different binding sites, they have they're not competing for the same site. So what's important to know is in this regard, the value that changes is your Vmax because they're non-competitive. If they were competitive and competing for the same site, you would change your Km or your potency, okay? I think I have more slides on that in a second. Yeah, so you could see here, so non-competitive allosteric binding, we're dropping our Vmax, okay? That's what changes. You can see our Km doesn't change. Oh, I'm sorry, hold on. We did change our Km. So we're looking at a competitive inhibitor here. I'm sorry, the graph just doesn't continue, but this will actually eventually go up to Vmax. So this is a good example of a competitive inhibitor because we could see that from the green line to the red line, we changed our potency. Now remember, Km is inversely proportional to potency, okay? So which means a lower Km means it's higher potency. So if a Km over here may be 1 milligram of a drug, all right, and the Km over here may be 10 milligrams of a drug, meaning this low Km is more potent, okay? So low Km, higher potency. If you have a competitive inhibitor, meaning they're competing for the same site, you're changing the potency. You're increasing your Km, you're decreasing the potency, okay? Just make sure you can get that straight in your head. And like I said, for Vmax, that's in regards to a non-competitive inhibitor. And again, it'll drop your Vmax, okay? Whoops. All right, so this is super toxic.
Hey, Brady, can you go back?
Yes.
People
Yes,
are really confused.
Let me see. I think maybe I don't have something from first aid. First aid has a good picture of this, this idea of this graph. So actually, let me do it on here. All right. So there are two scenarios that you want to worry about. You want to worry about a competitive inhibitor versus a non-competitive inhibitor. So if it's a competitive inhibitor, you are going to change the Km, meaning you're changing the x-axis, okay? From here to here. You see, this line right here, down here, has a low Km, meaning, and they're inversely proportional, meaning a high potency. Since this is a competitive inhibitor, right? We've changed the potency, okay? We've changed our Km, we've changed our x-axis, all right? So this point right here that we're looking at has a higher Km, meaning a lower potency. So we added a competitive inhibitor to it, okay? Now, the graph could also look something like this. Okay, now in this regard, we changed our Vmax, right? Our y-axis. Our Vmax went down, okay? So what this means is that we're looking at a non-competitive. So you just need to be able to keep these straight in your head. Competitive inhibitors are going to change the x-axis, which you can see here. Right?
Hey, Brady, there's confusion in the chat because allosterics are sigmoidal, and then
Yeah, I mean, these
Or is this
technically,
hyperbolic.
these, no, these, I'm sorry. I mean, I'm just drawing bad pictures. These technically are sigmoidal, right? They do look like an S. I just drew them from the point, yeah. So yeah, no, we're looking at sigmoidal curves. These are sigmoidal, right? Like
We're
that.
saying competitive, non-competitive would be hyperbolic versus sigmoidal would be allosteric.
Oh, I'm sorry. Okay. Regardless, what we're looking at here is just the change here, the change in your x-axis versus the change in your y-axis. Okay, you can actually look at them both ways. They're independent of each other. The point is, if you change the x-axis versus you change the y-axis, it'll define whether it's competitive versus non-competitive. Because when you look at hemoglobin, it changes into a sigmoidal curve, and then versus carboxyhemoglobin or carbon monoxide, it's hyperbolic. So just keep in mind, the whole point here is that if you change the x-axis versus changing the y-axis, what we're talking about, because that's all they're going to ask you at this point. It gets a lot more complicated with the pharmacology behind it, but just keep that in mind. All right, so DFP on acetylcholinesterase, it will bind covalently to the active site, okay? These are irreversible inhibitors. Just keep in mind that irreversible inhibitors covalently bind. Covalently meaning they're not ionic, they're not going to split up, they're covalent binding. Okay, so they bind with a high affinity, they're not letting go. All right, try this one. Oh, I know what y'all are, okay, I'm sorry. Yeah, I know what y'all are talking about. Yeah. So we're the log graph. Yeah. So let me pull it up on first day while y'all do this question, and I'll show y'all. All right, so for this is super important. This is going to keep coming up. But when we talk about nitric oxide works on the guanylate cyclase, the cGMP pathways. Okay, so you can see nitric oxide is used for heart, chest pain. It can help to vasodilate the vessels and get rid of that angina. But let me show y'all this. Okay, so, whoops. Shoot. Never mind. I'm gonna have to pull it up on my computer. All right, try this one, and I'll get it pulled up. No, I know what y'all. I know why y'all are getting confused. I'll show y'all in a second. All right, so look, check this out. So yeah, so look, if we're looking at it just in a basic sense, we're looking at these hyperbolic curves, right? So same principle here. If you change, so this green line is competitive, you see we changed our KM here, okay? The KM for the red lines here and the KM for the green line would be like over here. Whereas if you went red to blue, you're changing the Vmax. So it's a non-competitive inhibitor, okay? So that's like that. Now, you can change it into a log equation. And if that's the case, they look like this. Now, what you need, an easy trick for this, if you remember, if they compete across the y-axis, they're competitive. This is just a little trick. So this purple and this green line, they compete across the y-axis, it's competitive. If they don't compete, meaning this purple and this blue line, they're non-competitive. okay? So that's a trick way to do that. If they compete across the y-axis, it's competitive. Now, what you can also see here, here. Now, these are obviously sigmoidal curves, but in this regard, we're just looking at potency, right? We're looking at efficacy versus potency. Efficacy is related to the y-axis, which was related to non-competitive inhibitors, okay? Potency is the x-axis, and you're looking at changes in Km, changes in your potency, right? So, and you could see that here. So you change the Km. Again, a lower Km correlates to a higher potency. So as I mentioned, it doesn't matter the curve, however it's graphed, however it's drawn out, just keep in mind that if they change the y-axis, it's non-competitive, it's a change in Vmax. They change the x-axis, it's a change in Km, it's a competitive inhibitor, it's potency. And then once again, just in case y'all never heard this before, for the logs, right? So if they compete across this y-axis, it's referring to a competitive inhibitor. If they don't compete, then it's non-competitive. So that's just a little trick. All right. Okay, what are we doing? Hydrolysis of IP3. So we know, well, y'all are going to get into this a lot later. And one is a GQ pathway. So GQ goes through IP3. So phosphorylated version of it is PIP, or phosphatidylinositol. Okay, so star this. You do need to be able to whiteboard this out. You'll need to know it your whole time in med school. The point is the GQ pathway goes, they use C's for this. GQ goes through phospholipase C to increase calcium. It is very important to also know that DAG, okay, so after you get PIP2 and you split to DAG and IP3, DAG works directly on protein kinase C. IP3 works directly on calcium, okay, because they can ask you specifically. The whole goal is if you increase calcium, you'll get increased smooth muscle contraction, okay? The GS pathway, they use GS is stimulatory versus GI is inhibitory, but they work on the same pathway. So we're working with adenylyl cyclase, ATP goes to CAMP, protein kinase A, again, we're increasing calcium, okay? So you gotta know these, a lot of drug targets work on this that y'all will get to later, but yeah, okay, try this one. So efficacy would relate to allosteric regulation, because we know allosteric regulation is non-competitive. So efficacy of a drug can relate to non-competitive inhibition. Potency, the potency of a drug, it's a competitive inhibitor. So it's related to, it's going to be related to that x-axis. And again, that's a little bit, that's a little bit more than y'all need to know right now, but since y'all were curious about it. All right, so we're decreasing the amount of intracellular calcium by the decrease. So we know intracellular calcium going through this process will be the GQ pathway. So if we're decreasing the intracellular calcium, we're dealing with a GQ inhibitor, okay? So a bronchodilator is typically what they can use for something like this. And again, you got to know this pathway. All right, now, nobody likes this stuff. At this point, to be honest with you, PCR testing has become so cheap that this is a moot point. But we'll just touch on these a little bit. I think the most important thing for you to know is in the specific uses column, this is also on my drive to this chart, what to know, like what are the first line treatments for some of these? Like if they ask you sickle cell, you use restriction fragment length PCR. So knowing the different ones for that, another big one, anytime you're looking at large deletions or large duplications, you use array CGH, okay? So, but knowing these is just an easy, not an easy way, but just a good way of knowing what goes with what. But other than that, it's kind of, it's very tedious to try to go through all of these. So we're going to go through some practical applications for this. So try this one. All right. So let's walk through this. Okay, so each of these rows correlates to a different allele. Okay, so we have our normal allele and our mutated allele here. So this is normal. This is the mutated one, right? Little a. So we're going to go down the line. So you could see mom and dad are both carriers. They both have a normal and they both have a mutated one, right? They're heterozygous. You could see this in these columns here. So you can see both moms are carrier. Now, this child does not have a normal, right? You have to have two alleles, but all the fluid is in this in this well, right? So that means that the child has little a. There is no big A. So this must mean the child has the disease. This child, all of the DNA and the dye in the well is in this column, meaning the child only has big A. So this child's normal, and you can see child 3 is just like the parents, so it's heterozygous. So as long as you can work this out, the rows and the columns, this is pretty straightforward, okay? So just be able to tell which one goes with which. All right, try this one. I gave you a hint with this before, large deletion mutation. All right, as I said, large deletion or mutation, large deletion or duplication, you always want to do an array CGH. Also, just make sure you know that if you have a child exhibiting developmental delay, that's usually the first thing they do. See, some of these, if we go back to that little graph we were looking at earlier, it's good to differentiate them as, do they know what the cause probably is? Like, yeah, the kid came in with, we think it's cystic fibrosis, so we can kind of pinpoint the gene of interest. Whereas this kid's just got developmental delay. We really need to investigate everything. So yeah, that is a good question. So large, see, this is the thing, like you can use a lot of these different tests for different ones. If you would have to be a really large deletion to do a karyotype analysis, or even G banding. It's very low sensitivity. Okay, so that's the thing. Like it's just like for this situation. I mean, does it say exactly? Like G banding, you need like greater than 10 megabases to be able to analyze it. Array CGH is a little bit more sensitive, right? So no, array CGH is going to be more like more of a like a whole. You're looking at a whole, like a plate of the whole genome in a plate. So you do different wells, and you can see. Oh, it says 5 megabases for G banding. Sorry, it says 10 here, but go with whatever your notes say. Okay, 5 to 10. Yeah, it just has to be big, right? But anyway, so for array CGHs, yeah, you just use a bunch of different wells and you analyze everything. Whereas fish, you kind of light up the, if you've seen like the skyfish pictures, they light up the chromosomes to see if you can identify anything. But again, you're looking at whole chromosomes, and so you really have to have a really large deletion. So again, some of these come down to like, it makes sense in your head, like you could use this, but it's just some are just more sensitive for it. Yeah, no, I mean, that's the thing. It's hard to tell the difference. So G banding, so typically G banding is like the lowest yield because it's such a zoomed out picture. When you're looking at all the chromosomes, and karyotyping is a little more sensitive. But yeah, you really you want to try to remember these first line tests. I wish I had a better answer for you, but you could use like all of these. You could use a lot of these for the same thing. It's just what the teachers say is the best method to go about it. So that's why, you know, all of us not many people felt comfortable with this stuff on the test. You just kind of have to go with what it says. So go with that.
How many questions do you think they usually ask for these genomic?
I don't know, Lindsey, what do you think? 3 or 4, maybe? Something like that. They may give you, they like this little ASO thing. Like this.
God, I hated this part because it was so much and it was hard to get it down really well. I would say maybe 4 or 5.
Yeah. But you
it
may
was
get
enough
one
that
like
it
this.
annoyed me. It was enough
Yeah.
that I noticed it. I was like, oh, come on.
Yeah, so again, like they may give you one like this because this tests multiple aspects. You're also testing the genetic component of this as well. But again, yeah, it's hard to tell what's high yield and low yield even. That's why I would say memorize, like if we're talking about Huntington's and triplet repeats, you do a PCR. If a kid comes in with cystic fibrosis, you know you do an ASO. Just memorize it if you need to. Sickle cell, rip flip, right? Large deletions, duplications, go with an array CGAs. Do it like this if you need to. Do we have an idea what's going on? Do we have an idea what the disease is? Or do we have to look at a bigger picture to kind of try to isolate it? Okay, so you will have a couple questions. Hopefully they won't get too in depth with you. All right. And you can see this. So, and this is, you can see some examples here. This is why you do PCR for triplet repeats, and CGH won't pick those up, but array CGH, you're looking for these large deletions or duplications. All right, try this one. Diagnose the patient first. Always. That's your first goal. Whenever you read these in their second and third order, your first answer is, what does the patient have? So we know of 2 gain of function mutations we talk about, achondroplasia, and this one, these involuntary movements, these choreiform movements. This is Huntington's disease, those CAG repeats, these polyglutamate expansions, the exhibits anticipation, meaning every subsequent generation has more repeats, earlier onset. And for this, like we looked at in the graph, you want to look at PCR, okay? All right, and then this goes into a little bit of detail. It might be worth just looking over this, just have a general idea of what goes with what. But again, like we're saying, it's like, you know, sometimes it depends on what hospital you go to, what doctor you go to, what they prefer. You know, and like I said, PCR has become so cheap. They do huge panels of PCRs now, just investigating everything. So in real life, this isn't that big of a deal. So, I mean, it is a big deal, but it's like, you know, like I don't believe STEP really focuses too heavily on this kind of stuff. And again, this is just kind of a nice little summary of everything. Here's an example of fish versus skyfish. So skyfish can independently paint the chromosomes, different colors. Right here, you can see the fish analysis. Again, look how low, I mean, like, what are we talking about here? Like, you'd have to have a large deletion to be able to pick this up, you know, because we're just looking at these large chromosomes, just all bundled together. But yeah, so try to know the disease specific that go with each, and you should be able to answer the question. G banding isn't colored. Skyfish is colored like this, and even G banding isn't as fluorescent as fish is. It's just a zoomed out picture, so it's really low yield.
Are there any buzzword words that we would look out for to know to use fish?
Yeah, I mean, trisomies, monosomies. and big translocations. Yeah, I mean, it's hard to say. Rapid fish, trisomy. So yeah, I mean, even so, yeah, that would be the buzzword. If a kid comes in with Down syndrome to a fish, which makes sense, right? If you're looking at chromosomes and you have a trisomy, you would obviously see a third chromosome. Like, I think that's fair game, even putting it on the test, like you looking at all the chromosomes and seeing an extra one there.
So if they
Yeah.
say insertion, I can think of that as the same as a trisomy.
Not necessarily, because you could have an insertion of just a part of the chromosome or part of the DNA. So not necessarily. A trisomy is a complete extra chromosome in one of the, like of chromosome 21, you have 3 of them for Down syndrome. Yeah, but an insertion could be anything, any component of it. So not necessarily. But if you're looking for this duplication or insertion, you go array CGH. All right, I think we're almost done here. All right, Lindsay's got some cumulative questions she's going to run through with you guys real quick, and then we'll be done. But these will be good rapid fire for you guys to get ready for the exam. Do y'all want to break, or y'all want to just keep going?
Keep going.
All right, let's go.
Keep going.
Lindsay,
Can you
you're
give
up.
us a general sense of the most high yield subjects and topics? Like what's most high yield in order of that would be great.
So go ahead, Lindsay. Yeah.
I was going to say it's really hard because they're going to test every single lecture. So when you're going through lectures, think about it this way. If you only have 146 or whatever questions, then when you go through the lectures, only about 3 to 4 questions can be from a lecture. And so you go to a lecture, you get the concept down, and then you have to pick out what is, testable versus conceptual, and everything. So it's hard to nail down specific high yield concepts because it's everything, to be honest with you. Brady, what do you have to say about that? You're muted.
Yeah, it's really hard to say because we tell people when we just take an exam and then they'll take the exam and think the exact opposite. We'll be like, there weren't a lot of genetic testing on there, and then the next class will be like, it was all genetic testing. So it's hard to say, and that's why we approach these reviews as covering all the high yield stuff so that you're covered regardless. But obviously knowing the genetic components, being able to easily say, is it autosomal dominant, recessive, being able to identify the pedigrees, knowing how to quickly do the math problems in the beginning that we covered, osmolarity, tonicity, like this is all fair game and it'll all come up. You don't want to be able to just do it. You need to be able to do it quickly too, right? If you had all day, the test wouldn't be so bad, but you're on a time constraint. So keep that in mind.
Okay, question?
Yeah, so for example, I saw embryology on the quiz, but you said it's not high yield, but that just means if it's on the quiz, does that necessarily mean it'll be on the exam, or is it just okay?
I've had so many people ask me if different question sets are representative of the exam, and that's a really hard question to answer because sometimes yes, sometimes no. Sometimes they test you harder on the quizzes, and sometimes they focus on things in MCQs and in quizzes that they don't focus on in the exam. The best piece of advice I can give you is when you go through those IMCQs and when you go through those eSoft quizzes, don't just learn the base concept of what it's telling you. You need to go through and you need to know why each answer choice is right or why each answer choice is wrong. And really delve into that because they can switch those topics up on you any way they choose. So representative as in types of questions, style of questions, yes. Material, it kind of depends on them.
Do they ever recycle questions from the quizzes and the practice questions onto the exam?
Yeah, we have seen questions No, not verbatim, but very, very, very similar to ones that they give you.
Yeah, it's definitely worth going back through those, because even if it's not exactly the same question, it'll be the same concept for sure.
Yeah. And that's why you need to know why each answer choice is correct versus incorrect, because, you know, if they put something on the exam that is from an IMCQ or is from a Sakai practice question or ESOF question, it probably won't be verbatim. They'll switch it up on you, but it'll be the same concept. But if you don't recognize that they're switching it up on you, you may get it wrong just because it was muscle memory from when you reviewed the question.
Okay. That's gonna be the rest of my day, looking at questions.
Yeah, definitely. At this point, it's practice questions. It
100%.
really is.
Absolutely, yeah, for sure. The rest of the day, that should be your goal for sure.
Yeah.
All right,
And
Lindsey, you want to?
Yeah,
Sorry.
I'll get control of your screen if you don't mind, and then I'll go through the questions.
Okay.
And if you're getting questions wrong, please don't let that stress you out. I know at this point it is going to stress you out. Okay, my computer, I need to get my charger. And that's not really something you can avoid, especially since it's your first exam. But if you do get practice questions wrong, just do it as a learning tool. Just do it as a learning tool and forgive yourself and just go back through the notes and make sure that you can understand that concept. Okay. So we're going to go through these. We're not going to do the 72-second thing just for interest of time, but I will look at the chat and see the velocity of which you guys are answering. And if it slows down, I'll just give you the answer. Okay, question 1. Yeah, you guys are pretty much getting this all correct. I'll give you a few more seconds for a few more people to share their, yes, this is the question. So you can private message either Brady or myself with the answer. We don't have an answer. We're not using Turning Point. We're not using any of the other platforms. So just privately in the chat, but everyone's getting this right. It is C. So we talked about this in the review, and you guys also mentioned this a lot in the chat. Cholesterol does stabilize the membrane. I don't think I have to go through this any more than we already have, unless you want me to. So you can say yes or no in the chat. Okay, so everyone's pretty much saying no, so we're good on this. So we will move on. H-O is history of. I'm a previous scribe, and so a lot of my questions have abbreviations and acronyms. So don't hesitate to call me out on it and ask me what it means. Okay, we're kind of between 2 answers, which is fine. Okay, so before I give you the answer, I want to talk through this and see if you guys can get it. So family history, strong family history of cystic fibrosis. What is the inheritance pattern?
Autosomal recessive.
Autosomal recessive, good. Please, please, please know all of the inheritance patterns, because this is very representative of how they would do it on an exam. They'll give you the disease, they'll give you the pedigree or Punnett square or something, and they'll ask you about percentages, but they won't give you the inheritance pattern. So you have to know the inheritance pattern to get the question right. So we are talking about autosomal recessive. So we want the probability that 2-2 and 2-3 will have, what is the chance the father is a carrier? Okay, so father is the carrier. There is one thing and one thing only, because it's the sibling rule. And if you look at the sibling, they have it. And so that means that both of the parents, so 1-1 and 1-2, 100% they both are carriers. You know that for a fact. So now what we want to know is 2-2, this gentleman, what is the chance that he is a carrier? So sibling rule, it's going to be 2/3. It's just, that's a buzzword for you, but let's walk through it. I'm going to annotate. So remember, this person is out of the womb. So we know it, I'm going to do big, we're going to do big C. Little c. So this is our Punnett square. Probably shouldn't have chosen C, but we're good. So we know they cannot be homozygous recessive because they do not have the condition. You know it, they aren't bolded in, they do not have the condition. They cannot be homozygous recessive because this is autosomal recessive. So you have these chances left. So what is the chance that the father is a carrier? Now it's 2 out of 3. So that is the sibling rule. You can use that as a buzzword when you're talking about this. Yes, do we have a question? Yes, you can ask it.
So this is like a separate question I want to ask. So it's related to the genetics, but it's not pertaining to this question. Does that make sense? Like it's an actual, yeah. So I can ask it later if you want.
Okay, yeah, when we're done with the questions, go for it. Okay, so the father, so we're saying a couple, which is 2, 2, and 2, 3. So this is the couple that we're referring to. A couple, 2, 2, 2, 3. So what is the chance the father is a carrier? So we're talking about the father right here.
What was the question? Sorry.
Oh, somebody asked if how do we know who what the father we're talking about is? And the answer to that was that the question specified who the couple was. And so the couple is here. So who the father is. So the father of the couple would be 2-2. Okay. So this is your slide that relates to it. So it's just that 2/3 rule. Yeah, you guys are getting this right. It inhibits bacterial DNA gyrase. What is bacterial DNA gyrase?
Topoisomerase 2.
Mm-hmm. Topoisomerase, yeah. So do you guys understand the I can't think of words right now. Do you understand the topoisomerase concept? Why it's important, supercoils and everything? Yeah. Because you are releasing supercoils. So topoisomerase makes sure that, because when you stretch something out, it backs up and it tangles. I mean, that's a really crude way of putting it, but it happens. And so topoisomerase releases that tension. So if you don't have that, then you will get a lot of bad stuff happening. So again, crude way of putting it, but.
I have a question.
Mm-hmm.
So in our notes, you mentioned that ciprofloxacin inhibits DNA gyrase, but then you also mentioned etoposide inhibits topo2, and that you mentioned that both of them are the same unit. And then also etoposide is for anti-cancer, but then ciprofloxacin is antibacterial.
So
I'm just wondering what
ciprofloxacin is for bacterial DNA gyrase. So it's so it's the difference in organism there. So etoposide would be topoisomerase 2. But when we're talking about Cipro, it's bacterial DNA gyrase, which bacterial DNA gyrase is like our topoisomerase 2. It's just called something different. Does that make sense?
Oh yeah, etoposide so is for anti-cancer, and then the other one is antibacterial.
Yeah,
Okay.
eukaryotic versus prokaryotic. That's also a really important distinction to make when you are studying the pharmacology for term 1. Eukaryotic versus prokaryotic, because some things are only going to work on bacterial cells, which is a really good thing, because if it's going to work on all topoisomerase 2 and not just DNA gyrase, then bad things are going to happen, because you are going to effectively go into your host cells, your eukaryotic host cells, and like you said, etoposide, the anti-cancer, and you don't want that. And so a lot of these drugs are going to very specifically target prokaryotes. And so that's the difference there.
Okay. Like when it comes to like DNA replication, transcription, is it better to know the individual steps, or is it better to know like this, like medication or whatever that affects a certain step?
Both. Yeah, you do need to understand the enzymes. The big thing is the enzymes. Is going to be huge. And then of course the drugs. So, I mean, they're two separate concepts, so you need to take them separately at this time right now, because they're not combining the concepts in term 1 in FTM. So take the concept separately. So you do need to understand the steps. You need to understand transcription, translation, prokaryotic, eukaryotic, and you need to understand the mechanisms of the pharmacology here. Okay, so you guys were getting this right. I showed it to you in the middle because I clicked the page, but it's COP2. A way to remember, oh, I didn't have that in here. COP2, an easy way to remember this: 2 steps forward, 1 step back. So in tardigrade is forward, 2 steps forward. And then if we were talking retrograde, it would be COP1, 1 step back. So that's a clever, easy way to remember it if you have not heard that trick already. I can't answer in the chat right now. I can't type in the chat right now. So if you have a question, please direct it to either Brady or the rest of the group. Okay, we're getting a lot of mixed answers, and I always do. This question always has a lot of controversy on it. So we're going to walk through it step by step. Okay, lower melting point. What do we need to have what is the melting point of a DNA double helix dependent on?
Could I?
Number bond.
Hydrogen bonds?
Yes, hydrogen bonds.
Yeah, I was gonna say, can I walk through my process a bit?
Can I ask my questions?
Oh yeah, sorry.
Is that okay? It's just so that I can walk through it and not get lost. Okay, so hydrogen bonds. So how many hydrogen bonds are between C and G versus A and T?
3.
So 3 are between C and G, and A and T have 2 between them, meaning that A and T, the higher concentration of adenine and thymine or tyrosine are going. My God, Lindsay, sorry. A and T, if you have a higher concentration, you're going to have a lower melting point. And conversely, if you have more in C and G, you're going to have an increased melting point simply because you have more bonds to break through. It's as simple as that. So you want to pick the double helix that has the highest concentration of A and T. So in A, we have, I'm going to annotate again. In A, we have 20% cytosine, which means we also have 20% guanine. because these are bonded together. So you have to have the same here and the same here. So this is 40% CG and it's 60% AT. Okay, so answer choice A is 60% AT. B, 40, again, 40 would be C, 40 cytosine, which means you have 80% CG and then only 20% AT. Here, it's going to be 50-50. Here, it's essentially the same as B. And so the answer here is going to be 20% cytosine because this is going to give you 60% A and T, which means that that is the highest concentration out of all of these answer choices.
Can you explain the lower melting point part again?
Yeah.
And how that breaks the bond?
Yeah. So between C and G, you have 3 double bonds. Between A and T, you have 2. So when you increase the temperature, you're weakening these hydrogen bonds because hydrogen bonds are very, very, it's essentially just an association. They're not stuck together. And so when you heat things up, you can break these hydrogen bonds. And so when so it takes longer to break 3 than it does to break 2. And so this is going to have a lower melting point because it's not going to take as much energy, because heat is energy. It's not going to take as much energy to break both of these bonds. Whereas C and G, you're going to have the higher melting point because it's going to take more energy to break through 3 versus 2 bonds. Does that make sense?
Yes.
Okay, cool. Anybody else confused on that?
I have a question. So I understand the melting point and then the hydrogen bonds part, but I don't get how that answer choice A over D.
So this is 40% AT, meaning this is 60% CG. This would be 40% CG and then 60% AT. So the lowest melting point is going to be the one with the biggest concentration of A to T ratio. Does that make sense?
Yes.
So this has 60% AT, whereas this just has 40% AT.
This is a crazy tricky question.
Yeah, I know. That's why I did it, because I wanted you guys to think about it. Yeah. So
we just look at the opposite of the answer choice.
No, I would not recommend just looking at the opposite of the answer choice. You need to work through this. Because I'm going to erase this and we're going to walk through it one more time. So if you have 20% cytosine, let me get my stylus for this. I'm using my mouse and it's not as accurate.
You need to like go slow in this problem.
Yeah.
That's really it.
Yeah. Okay, so we're working on A right now. We have 20% cytosine. C and G go together. So if you have a concentration of C, you're going to have the exact same concentration of G because they bond together. It can't be any other way. So if you have 20% cytosine, you are going to have 20% guanine, meaning your CG concentration is 40% because you're adding 20 plus 20. Does that make sense?
Okay, so we're trying to look at the AT, basically.
Yes, you're looking at AT. Wait, hold on. I'm confusing myself. Sorry, if I talk about something for too long, my brain's gonna flip and it's gonna be yeah, okay, I'm good. Because A plus T plus C plus G has to equal 100, right? So all 4 bases has to equal 100% of DNA. And so 20% cytosine means you're going to have 20% guanine because these go together, meaning that you have 60% left over. So it would be 30-30 for AT. So, 100 minus 40 is 60. So that's 60% AT. That's the concentration of AT in example A. So A through C is kind of the exact same thing. 40% guanine, you're going to have 40% cytosine. You add those together, that's 80% G and C, meaning 100 minus 80 is going to be 20% AT. So you have 10% A, 10% T. And then C, 25 A, 25 T. Then you would also have 25 for C and G. And then, so here, this is where it deviates. I did this on purpose and this on purpose because I wanted you guys to get tripped up. So you understood you need to slow down and you need to look at this. So if you have 40% AT, this is the entire ratio. This is all A and T, meaning you have 60% C and G. So notice I just put one base here versus two bases here. Does that make sense? So this means that the entire ratio of A and T together is lower than the entire ratio of A and T together in choice A. That's why it's correct. Yeah, the question might ask highest melting point. I put it on here to intentionally trick you. They're not going to intentionally trick you. I wanted to intentionally trick you to make the point that you need to slow down and also to show you how to work through some of these things, because this question is deceptively easy, right? You look at this and like, oh, we're just calculating different concentrations of a base in a DNA double helix. It's deceptively easy, right? Melting point, you understand the concept, you understand it has to do with hydrogen bonds, you know how many are between A and T, you know how many are between C and G. Easy, right? Well, when you go to the answer choices, you need to be able to take it one step further and understand how do you get to that N 100% and then dividing it up. Okay, did that make sense? Do I need to go over anything else in this question? I'm fine if you guys want me to go over it more.
So just to clarify, low melting point would mean like a lower temperature.
Yes.
Which means it takes more to melt it.
Less.
It takes less to melt it.
Well, yes, it would take, oh my goodness, sorry. This is, if it's a low melting point, that means that it doesn't take as much temperature to melt it. So it's because it's going to melt at a lower temperature, meaning that you don't need that much energy because temperature is just energy.
Which is why we were focusing on AT for this.
Yes.
Okay, but if it said higher melting point, which means it takes a lot more temperature to melt it, you would look for the GC content.
Yes.
Okay.
Yeah, keep in mind that the GC combination has 3 covalent bonds to it. The AT combination has 2 covalent bonds. So it's always going to be hydrogen, sorry. It's all sorry. It's always going to be easier to break an AT bond than a CG bond. Okay, so yeah, a lower temperature would, anytime it melts at a lower temperature, you're talking about more ATs.
Yeah. Are we good with that concept? I knew it was going to be tricky. Every single time we do this review, this happens every single time. So
I guess it's just the definition of what a low melting point means. That is, I think, the confusing part.
Okay, yeah, low melting point, it doesn't take as much energy to break the bonds, and so it's easier to break 2 than it is to break 3 bonds. Does that make sense?
Hello?
Okay.
Hello?
You have a question?
Yeah.
Go for it.
So if you're talking about percentages, why is the last answer not the right answer? Because you are talking about lower melting point.
Right.
Because the first
It was
answer had
only
60,
40%
80.
AT.
Yeah.
It was only 40% AT versus answer choice A that had 60% AT.
60%. So yeah. So why didn't you choose the 40% if it's lower? We're talking about
Because
lower
you
melting point.
want more AT.
Okay.
Yeah.
Okay.
Yeah.
Okay.
You want more AT because those are the easiest bonds to break. So if you know one thing over the other is going to be easier to break, you want that thing to be in excess. Because if the harder thing to break apart is in excess, it's going to have a higher melting point. Because we're not talking about a single bond, we're talking about the double helix as a whole. And so you may break so you're heating something up and you may only have 20% AT, meaning you're gonna have a higher melting point. So at a certain point, yeah, the AT are gonna be dissociated and the CG are not. But if we're talking about the double helix as a whole, just one unit, if you are trying to break apart that single double helix, if you have an increased CG content, it's gonna take a lot more energy to break it apart. Thus, you need a higher temperature. Does that make sense?
Okay. Yeah, makes sense. Thank you.
Okay. Sometimes I feel like I don't make sense. So you guys feel free to let me know if I'm like talking in circles, because that happens and it's not an uncommon thing. So you won't offend me if I don't make sense. Okay, let's answer this question. Some people are already answering it. Okay, answers are coming in much slower this time. Yes, we will definitely explain this. Okay, the majority are getting it correct. The answer is lamellipodia. This is a definition from your notes. I don't have an accompanying slide, I don't believe, but I will annotate and tell you what I mean. So we're talking about actin polymerization and then positive movement forward. This is a simple definition from your notes. It's lamellipodia. So if you remember this structure right here, this is the lamellipodia right here. It's so what's happening is actin polymerization. Remember, your cytoskeleton is made up of actin, and so actin polymerization mean adding to. So you have, in addition, the actin is basically just forming this little structure, and what happens, it forms out here. And this is going to propel this thing forward. And so this structure that's what we're talking about, is the lamellipodia. I think they had like 5 slides on it, and it said almost the exact same thing every single slide. And in every single slide, they bolded the words actin polymerization. That's a thing they love to talk about. Does someone know, Brady, do you have that slide somewhere? I don't think I put the accompanying slide on here.
Which one?
It's not on.
I'm eating
lamellipodia.
Sorry, I'm eating.
No, you're fine.
No,
I was eating during yours.
I'll see if I can find it.
Okay, it's just a definition from your notes, quite honestly. Okay, I can't. If I do it, it's gonna. So does that make sense though? It's just a definition. Okay, everybody is answering this question now. I can't go back because if I click to get control, it's going to show you the answer. kind of talked about this earlier because we were talking about DNA, bacterial DNA gyrase, and we were talking about topoisomerase 2. We're split between two, but we're split between the two that I would expect you to be split between. Okay, the answer, come on. Oh, where did my mouse go?
Can I go for the definition of I and H?
Inhibit, sorry.
Oh,
That's my own abbreviation. It's not an accepted abbreviation. I apologize for that. Okay, so if we are inhibiting topoisomerase, then you have a buildup of supercoils. A lot of people put B, but topoisomerase is going to introduce negative supercoils, if I remember that correctly. It's going to introduce negative supercoils. And so since we can't introduce the negative supercoils, then we're going to have a buildup of positive supercoils. So that is why the answer is A. It is a definition from your notes. Do you have a question? Cheyenne? Okay, you guys are all getting this correct. That's awesome. Positive feedback, it's childbirth. Essentially, positive versus negative feedback. Positive feedback, the presence of something is going to increase itself. So until an end point versus negative feedback, you basically have too much of something and something signals back to what was making it to turn it off. So you're basically saying, hey, we don't need this anymore. Stop making it. Versus positive feedback, you keep increasing something, increasing something, increasing something until you get to the desired endpoint. Yes, topoisomerase is going to reduce positive supercoils by introducing negative supercoils. That's how they do it. And then what is an example of negative feedback? Essentially everything else in the body. You get a lot of that in the hormones. And so if you have too much of a hormone, you need to negative feedback back so that you don't have, so that you turn it off. So a big example of that is the thyroid hormone. The thyroid makes T3 and T4. If you have a lot of diseases, you know, hyperthyroid. And so sometimes a negative feedback mechanism is messed up and you can't turn it off, but on a normal healthy basis, if you have too much T3 and T4, it signals back to your pituitary to turn off TSH because TSH is stimulating. So yeah. Topoisomerase reduces positive supercoils by introducing negative supercoils. So positive versus negative there.
I have a question again.
Mm-hmm. Go for it.
So sometimes they give the option of positive feedback and feed forward regulation, and I'm not sure what the difference is.
Okay, yeah, does someone, I can't think of it off the top of my head. Does someone know the definition of feed forward real quick?
I do.
Go for it.
So in class, he said that, like, for example, if you smell food, you start salivating. So like you don't even need to use your saliva yet, but your body's getting ready for it. Or like before a race, your heart already starts racing to get you ready to like start
It's
running.
basically an anticipatory mechanism that prepares you for something. So your body knows something is about to happen and it basically prepares you for it. Thank you for that.
Can I ask a question about the previous question we did really quick?
Yeah, go for it.
Okay, so if topoisomerase introduces positive supercoils.
Negative supercoils.
But I looked on the notes and it says gyrase introduces negative supercoils.
Gyrase is the bacterial version of eukaryotic topoisomerase 2.
Because it said that gyrase does negative supercoils while topoisomerase does positive supercoils before the protein. So wouldn't it technically be adding negative supercoils if there's a toxin?
I would have to look at the slide.
Okay.
Yeah, I'll check on that. I mean, if somebody else has something to add to that question, I'm gonna write this down for myself so that I can look at the slide and clarify that.
Also, when you say positive and negative, does that mean like clockwise and anti-clockwise? Okay.
Yeah. Mhm. Okay, I wrote that down for myself. I'm gonna look it up to make sure that is correct. And I'll post it on my page later and just say, hey, for those of you that are in the review, this is the clarification that I promised you.
Okay, thank you.
Yeah.
Sorry, I think an easy way to think of it is like a positive supercoil is like you're winding it up like really tight. Okay, so the whole idea of adding negative supercoils is just clipping it and alleviating that positivity, right? That the same thing, you're saying the same thing if you're saying I'm getting rid of the positive supercoils is the same thing as saying I'm introducing negative supercoils. So if you take two strings and you keep winding them up, it gets so tight at the front end. That's what's happening to the DNA. So the topoisomerase on the backside has to clip it and just let it unwind a little bit so everything can kind of fall back in place. Okay, so that's the whole idea. And yes, the gyrase and the topoisomerase, they're basically the same thing. They all introduce negative supercoils to alleviate that positive front end.
I guess I was confused because the question says there's a toxin that's inhibiting topoisomerase.
Right. So you would have a buildup of positive supercoils because you're not
Right.
introducing negative supercoils. The difference between topoisomerase 1 and topoisomerase 2 are how they are doing it. And so topoisomerase 1 is, I believe, correct me if I'm wrong, topo 1 is going to break one strand and let it release and introduce the negative supercoils versus topo 2 is going to break both strands, let it release, and then bring it back together. So that's the difference between topo 1 and topo 2. But they but the supercoils, it's a positive supercoil. So as helicase is opening up the replication fork, behind the replication fork, you're getting an increase in positive supercoils. You're tightening that helix. You're tightening. And then topoisomerase comes in and it releases that tension. And the way it releases that tension is by ligating one or both strands, topo 1 versus topo 2. And then you're essentially introducing negative supercoils to relieve the tension you are getting from the positive supercoils.
Oh, so it's relieving the positive supercoils.
Yes.
Yeah, you're just clipping it and letting it unwind. Like
Yeah,
it's
you're
all
just, you're
bunched
just
up.
letting it unwind. Sorry, that's a much simpler way of putting it.
I mean, and you could think of it as clockwise and counterclockwise if you want. Like if you keep turning something clockwise on the, if you hold the other side taut like that, you're going to keep adding stuff to it until it's so tight that the DNA is just going to snap, right?
Yeah.
So if you clip the end, then you could just let it unwind a little bit, right? So it could all just kind of spread back out. Yeah, that's the whole idea.
So I think the confusion is just the terminology of positive versus negative supercoils and what happens with topoisomerase. Am I correct in saying that?
Yeah, I get it now. Okay, that makes sense.
Yeah. So I don't think I understood your initial question fully. So we're good. Are we all on the same page now?
Yes, thank you.
Cool.
There's like a really short DLA that where she actually uses like the string with different colors. It's actually a really short video. If it's still unclear to watch, it's helpful.
I don't think we had that.
Yeah, I know she like cuts the string for DNA gyrase, or she like just loosens it on topoisomerase.
Yeah, it's somewhere in there with different colors to differentiate what's what. But I remember watching it and being like, wow, that was, and it's very, very short section of it.
I don't think we had a cool DLA like that. I don't think any of ours in term 1 had videos. Oh.
It was like 3 minutes.
Okay, so I already gave you guys this answer because Brady and I were clicking around on the screen. Sorry. But it is tumor suppressor. So you guys are getting it right anyways. But the big thing here, we're talking about NF1, which is neurofibromatosis, mutation on a chromosome encoding a protein. So we're getting a dysfunction of that protein. What is the normal function of this protein? All you need to know here is that the NF gene is a tumor suppressor. So neurofibromatosis, if you've ever seen pictures, you get tumors essentially all over the body. It's just uncontrolled tumor growth. And so the NF gene creates a protein and that inhibits that. So tumor suppressor, all of the diseases they talk about, yes, please know the gene that is associated with it because they like to test that as well. That would be considered a high yield thing. If you want to say that is the genes associated with all of the diseases that they give you. Yeah, you guys are getting this correct. We have two other answer choices, which I anticipated you choosing, but most of you guys are getting it correct. It is D, absence of DPPC. Yes, please know I put the entire word here without the acronym for a reason, and that reason is because they won't always be that nice to you. So please, please, please know these words written out. It's not A because we are at 20 weeks gestation, which means the lungs are fully developed. 20 weeks is the point where you do have good lung development. And at 20 weeks, this is when you're also getting the production of the surfactant. You'll learn that in later terms. But all you need to know right now is that what we're talking about is the absence of DPPC. Why is it not B? Because LS ratio above 2 is what you want. The LS ratio of 2 to, what's the abnormal ratio?
Anything less than 2 to 1. So.
Yeah, anything less than 2 to 1. So this is the normal ratio. And then infection, that's way beyond the scope of this question, but they love to focus on the DPPC, which is a component of surfactant. Yeah, you guys are getting this one correct. The answer is X-linked recessive. What's the disease? Somebody said in the chat privately, but.
It's either muscular, Duchenne's muscular diff or Becker's.
Yeah, so right here, we're just talking about muscular dystrophy. You don't have to distinguish between the two. DMD is the more fatal one. And so you might not even get to 5 years of age, quite honestly. But the things here, large calves bilaterally, that's a big one to clue you in on muscular dystrophy. And then trouble getting up from a sitting position. Both of those can be used in your vignette to key you in on muscular dystrophy.
Will they ever try to trip you up between the two dystrophies or? Okay.
So think about it this way. So Duchenne's, usually they're wheelchair bound by 12, they die by 20, right? Becker's, so they have a reproductive fitness of 0, meaning they usually don't reproduce, right? They don't get to reproductive age. Becker's, they do, they could live to 30 or 40. So just think of it as a spectrum. Duchenne's is just a worse version of Becker's.
Yeah, because it has to do with the extent to which you have this genetic dysfunction, but it's still muscular dystrophy.
Yeah, like Becker's, you have some dystrophin there, but Duchenne's, you practically have none, and it's a structural component of the muscle. So.
Difference between myotonic and muscular. Did we do myotonic in term 1, or was that just you had to know what the inheritance pattern was?
I think it's later on in term 1. Myotonic dystrophy is more of like a clonic positioning.
Yeah.
So like when you think of myotonia, you think of like contracted arms, like it's a forceful, but it is different. It's
a different inheritance pattern.
Right.
Yeah, please know the inheritance patterns. I cannot stress that enough. If you want a high yield thing to remember, inheritance patterns.
That's autosomal dominant, right?
Yes.
Yeah, myotonic dystrophy.
And then that's just like upper arm, like upper limb weakness.
Typically.
Or just weakness in general.
But
okay.
I think it starts in the upper limb, but it's also a trinucleotide repeat as well. So you see that anticipation process. Yeah.
Okay. Yeah, because we like briefly went over it, and I've seen it on some practice questions.
Yeah, if it's there, it's probably like a distractor right now. Y'all, I don't think y'all have gotten into it too much. Yeah, they'll throw it in as a distractor though.
Yeah. Yeah, you guys are getting this question right. So they aren't going to have a question like this on the exam. I put this question in to talk about the importance of conceptual information versus testable information, because you do need to know these concepts, but you need to know these concepts in the sense that they're going to say this molecule has a reflection coefficient of this, and you are going to use that piece of information to calculate, osmolarity, tonicity, or whatever they want. But the answer is going to be reflection coefficient of 0. So permeability coefficient 0.7. Anything around this is only partially permeable. Reflection coefficient of 1. This means it is impermeable. And then permeability coefficient of 0 is impermeable. Here's another one of these. So we'll work through it. Don't worry. Okay. So always know that ISO is going to be 300 unless specified. Sometimes they'll specify something else. Sometimes they'll say 280, but unless otherwise specified, you can assume that isotonic is, or isoosmotic isotonic is 30. This is normal. 300, my God, 300. Okay. So now let's walk through this. We have 100 millimoles of NaCl and 400 milliosmoles of urea. Now, the first thing I want to point out is the difference between millimoles and milliosmoles. What do we do when a value is placed in millimoles versus milliosmoles?
Multiply by you know what I'm trying to say.
The number of individual molecules, individual atoms there. So if we have 100 millimoles of NaCl, that means we have 200 milliosmoles of NaCl. That's how you convert it to milliosmoles. You really just multiply this number by the number of solutes. Okay.
Wait,
so
if it's like
one.
If it's like CaCl2, you're multiplying it by 3 then?
Yes, I'm pretty positive. So somebody correct me if I'm wrong.
What was the question?
CaCl2.
I saw some things on the calcium chloride, so that would be 3.
Yeah, you're right.
Yeah.
Okay.
Yeah. Okay. Thank you. So, so now we have 200 plus 400 we have 600 milliosmoles. Now, I haven't talked about osmolarity or tonicity yet because we're just working with our initial numbers right now. So we have 600 milliosmoles, and no. Sorry, I was trying to move the chat box and okay, I'm going to erase this. Okay. Your red blood cell here is 300. So, and this is your solution right here. So a red blood cell placed into a solution that is 600 milliosmoles. What is the relationship of the solution to the red blood cell? Hyper, iso, hypo. 600 versus 300. What is it? I know the answer is on the thing, but
it's hyper.
Solution or the cell?
It's always a solution. Always a solution. That confused me for so long, like middle school, high school, like college, because I didn't understand what they were talking about. Like, what are you talking about? Hyper? I understand the numbers, but it's always the solution. You're talking about the solution. So this is hyper. Now, this is when we're going to get into osmolarity versus tonicity. This is the moment that this red blood cell was dropped into the solution. This has had no time to equilibrate, meaning nothing has moved across the cell membrane at this time. This is osmolarity. This is the very moment the red blood cell has been dropped into the solution and it has not had enough time to equilibrate. That's what this is. So this solution is hyper osmotic with respect to the red blood cell. This is at the time the red blood cell was dropped. Now, we sit for a few hours. The solutes are now able to equilibrate. Now, I didn't tell you reflection coefficients in here, but urea is one of those that you just need to know is permeable. It has a reflection coefficient of 0. It will completely equilibrate across the cell membrane if given time. So, and then NaCl is impermeable. Again, I didn't tell you, but this is one of those that you just understand it's impermeable, reflection coefficient of 1. It's not going to cross the cell membrane without a transporter, but we have no transporters here. Okay. So since we have given this cell time to equilibrate, that means that the urea, which is permeable, it's going to cross the cell membrane, is now the same on each side. What that also means is that we can eliminate this from our equation at this point because it's negligible with respect to our calculation at this point since it has formed equilibrium. Meaning we are only looking at NaCl. So over time, so 4 hours later, still have a red blood cell, it's still at 300, the urea has had time to equilibrate, but you still have the 200 milliosmoles of NaCl because this is not permeable to this membrane without the respective transporters. So this solution is now hypotonic with respect to the red blood cell. Tonicity is over time. Osmolarity is at the exact moment that the red blood cell is introduced into that solution. Did that make sense? I have one yes. I don't want to move on if there is a lot of confusion. Okay, I have more yeses. Cool.
Is that always the case for these problems? That's always going to be the situation?
I want to say yes, but at the same time, I don't want.
I think that there's some that specify that they're looking for the cell, but I think if they don't specify, like Lindsay said, then you always go with the solution.
You can't always go with a yes. You can't give an absolute yes on any question.
Yeah, but usually if you're talking about the tonicity versus osmolarity, you're talking about the solution with respect to the red blood cell, because it's going to be a red blood cell in a hypertonic solution, in a hyperosmotic solution, that kind of thing. So it's the environment with which the red blood cell is in. You're talking about the environment, and so that environment is a solution. So in the body, you're talking about plasma, you're talking about blood, you're talking about everything that is sitting around the red blood cell. So you're talking about the environment with respect to that red blood cell, because that's how water is going to travel, and it's going to dictate how the cell responds. So shrink, swell, stays the same, what have you.
Yeah, I agree. So it's always going to be the extracellular fluid, because you want to know the composition of the fluid in regard to the cell. If they ask you about the cell, they'll ask you, is the cell going to swell or lyse under such conditions, yes. Right? So they'll
That's how they
you,
would ask about the cell.
If the fluid is hypoosmolar to the cell, that means water is going to go into the cell. It's going to cause the cell to swell and potentially lyse. Okay, so that's how they would phrase something like that.
You just said hypoosmolar would cause it to swell.
Right, which would mean there's more stuff, more particles in the cell, correct? So water's going to go to the place with more particles. So water's going to leave the extracellular fluid and go into the cell.
Okay. Oh, sorry, I couldn't see the answer choices. I apologize, guys. So we'll just walk through this one. The parents of a child diagnosed with Klinefelter's wants to know how it is transmitted. And then after extensive genetic testing, child found to have both an A and B copy of the repeated chromosome. Where did the non-disjunction take place? You guys have a slide of this in your notes, and I think Brady said this pretty nicely too with his little trick here. And he pointed out that Klinefelter's is a big one that they like to test because it is a little more common, a little more high yield, but it is going to be in meiosis 1. Brady, did you have something to say?
Nope, that's right. Yeah, so X, X, Y, right? So you have, after that initial X, you check the other two, the little trick. If you have one of each, it's in meiosis 1. Yeah, it's just like we talked about earlier.
Okay, and I put the slide on here.
Do they ever talk about Robertsonian translocation where you get the 45XX and the 45XY?
Yep.
Yeah, you could.
FTM2. FTM2.
Well, they did briefly in for FTM1 here, but he said not to worry about it because they're going to go more in depth later.
Yeah.
Mm-hmm.
They just related to like the acrocentric chromosome.
Exactly. That's the whole point. If you have those little nubs, the little acrocentric part, if you have some sort of translocation, you could just lose those little nubs, those little pieces. So that tends to happen sometimes. Sometimes in Down syndrome, that'll happen.
Mm-hmm. Okay. Is there anything in here I need to? HA is headache, but you don't really need to know that for this question because it is not a part of the STEM. BSG is blood sugar. Okay, so you guys are getting this correct. It's GLUT4. For FTM1, there are a few that are high yield that you need to know. I promise you, this gets so much easier as you go on because you are going to go over it so many times, and you are also going to relate it back to, you're going to relate it clinically. So GLUT1 is more the brain. It's kind of constitutive because the brain always needs glucose. If you can't get energy to the brain, you're pretty much screwed. So GLUT1's pretty much constitutive. It's in the brain. That's the big one. And red blood cells, I believe, also have GLUT1s. GLUT2, this is insulin independent because GLUT2s are in your pancreas, on your islet cells. And so this is going to be able, oh my God, it's in the liver, Lindsey. Liver and pancreas. And then GLUT3, I don't remember GLUT3.
GLUT2 has a lot of locations. You're not wrong. There's like 4
Kidney, liver, and pancreas, I think is what it
Kidney,
is.
liver, and pancreas. Yeah, it's specific though, because it's not insulin dependent. And so you'll get into it in the term too, but the reason being because these organs are going to help sense blood sugar levels, and in response to those blood sugar levels, you can get release of insulin, or in the case of the liver, you can get either, it can turn off different metabolic processes. Again, that's term 2 stuff, not going to really go into that. GLUT3, I don't remember what GLUT3 is off the top of my head. And then
it says
GLUT4,
brain, but
neurons.
I confuse it with one. How do I?
It's neurons.
It's neurons. Neurons are in GLUT3, but
How do you
GLUT1
distinguish that from one?
They're both there in the brain. But yeah, GLUT3 is specific to neurons. GLUT1 has RBCs as well.
Yeah.
For
And
GLUT1,
then,
sorry.
huh?
For GLUT1, do we just assume more RBCs?
You don't have to assume more RBCs. RBCs in the brain need a constant level of glucose because they need energy. So just know that both of them have it. You wouldn't need to distinguish, but like more or less. But then GLUT3 just focusing on neurons. And then GLUT4, this is insulin dependent. You're going to have this in your adipose tissue, your skeletal muscle. But this is glucose. This is insulin dependent. This doesn't take in glucose unless you have insulin present. Can go into diabetes here, but that's out of the scope of term 1. But the big thing, know where these are located. You'll have a couple questions on these. It's not going to be a handful, just a couple. But all of these are facilitated. I'm pretty sure all of them.
Do you say that GLUT2 is glucose independent?
It's insulin independent. I originally said glucose independent, but I misspoke. It's insulin independent, but it is glucose dependent. It will not really. It's just it's there. And it can take up glucose so that the cell can sense it.
Okay, and then GLUT4 is insulin dependent.
Yes.
Okay, thanks so much.
Yeah. Oh yeah, there is one on there, GLUT5, that I didn't put. That is yeah. And it's different too. It's going to be the secondary active transport. So with respect to the ones I had on the slide, GLUTs 1 through 4, it is the facilitated fusion, but GLUT5 is the kind of outlier of the GLUTs, and that one is the fructose, and it is secondary active transport, and it's in the gut. It's also called like SGLT, right? Or is that not the same thing?
Not the same thing.
Okay. All of this stuff runs together at this point now. Quite honestly.
SGLT is secondary active transport, whereas the GLUT receptors are facilitated diffusion.
I had a question about that. So I know one of the SGLTs is related to the intestinal lumen, I think, and one of the GLUTs is intestinal mucosa.
Yeah, you
so
don't need
it would.
No? Okay.
Yeah, you don't need to know that.
It's all
for
the
right now.
same. It's all the same. Yeah. It's
Okay,
all-
because in
yeah.
OPLG they asked that, and I couldn't tell the difference.
The mucosa is the lumen. Like that's everything goes through it. So
Oh,
you should be
okay.
fine. Yeah.
Yeah, in one of the OPOGs, they give an example of eating gum, and they put like digestion and then insulin mucosa, and then I had chosen GLUT2, and then I got it correct. They put that it was the SGLT. So I didn't know how to differentiate between the two.
I don't. I'd have to see the question. I'm
I
not
think
sure.
it was poorly written, to be honest.
Okay.
You guys are getting this one correct. It's microvilli. So just knowing the function of all of these, stereocilia are they are in the male reproductive tract, and they are movement, I believe. Microvilli is absorption, because microvilli, the function of it is to increase surface area for absorption. Cilia, these have some motor, but I can't form sentences right now, guys. I'm sorry. Cilia are in various parts. It's a big thing is the mucociliary motor in the respiratory tract, and then in other places. But this is kind of helping sweep things along. That's what it is. That's what I was trying to get to. It helps sweep things along, and then flagella is locomotion. Sorry, did that before I wanted to. But you guys are all getting this correct. Yes, this is the difference between necrosis versus apoptosis. The big thing to remember is apoptosis is very organized cell death, whereas necrosis is not organized cell death. So cell shrinkage is apoptosis, because apoptosis is organizing, it's an organized breakdown of the cell. So as it's breaking everything down, it's shrinking. Plasma membrane blebbing, that's also apoptosis, and an aggregation of chromosome, apoptosis. Cell swelling would be necrosis, because you it's a very disorganized traumatic cell death, and so you're getting the swelling. So please know the difference between those two. There will be like one, maybe two questions that will have you differentiate between the two histologically. By definition, not by an actual histological picture.
Are these distinguished when they talk about the extrinsic and intrinsic apoptosis? Because I'm still trying to understand those. Okay.
You can, it's extrinsic versus intrinsic apoptosis is only with respect to how it is initiated, how apoptosis is initiated. Once apoptosis is initiated, the cascade that it goes through is the exact same. The only thing is how you get to that cascade, how you initiate that cascade. But you cannot differentiate between the two if you're just talking about histology.
Okay.
Or you might, I don't know. I'm not the subject matter expert, but at my level, you can't. That's more of a how do you initiate it?
How do we determine if this is from injury or like a programmed internal cell death?
So we're talking about a gangrenous toe. And so gangrenous is a necrotic tissue. Does that make sense?
Yes, thank you.
Okay, cool. The nasty black green stuff. So you may be thinking, Lindsay, why did you do A through G? Because they will do A through G on your exam. They will have long lists. So just prepare yourself for that. It can happen. That is when you use the strikeout function on ExamSoft. Brady and I both talk about this. Utilize all the functions of ExamSoft to your benefit. So the strikeout function, the highlight, everything. Use everything to your advantage.
How can you strike out?
On the far right, at the very far right,
There's like a little eyeball.
Yeah, it's an eyeball. Yeah, thank you. And if you click that eyeball, it strikes it out. Okay, you guys are all getting this correct. It is hemidesmosome basement membrane. So it is a large, taut, fluid-filled blister. I didn't give you a whole lot of information here, but I was hoping you keyed in on the description of the blister. This is going to be more of a bullous pemphigoid situation. And so Brady talked about how, you know, bullous below, you have the hemidesmosomes at the level of the basement membrane. The way I differentiate pemphigoid vulgaris versus now I can't even remember the names. The way I differentiate the two different blisters is because bullous pemphigoid, there we go. It's like a bowl, which it's big and strong and stubborn. And so those blisters don't break very easily versus pemphigus vulgaris. They have that shearing effect, and the blisters are going to break very easily. The reason being because it's the desmosome, so that's a lateral specialization. And so since the cells on either side of each other are not held together, you of course are going to get that easy breaking of the blister, versus here it's at the basement membrane. However, the desmosomes are intact, and so the cells next to each other are still intact, and so it's a taut blister. It doesn't break open very easily because the structural integrity of the lateral specializations are intact. But more important, know that it's hemidesmosome versus desmosome, and then you need to understand what the proteins are that are associated with it. So like integrins, desmoglians, all of those fun things.
So the desmosomes are in fact on the lateral side.
Yes.
Okay.
Yes. They're gonna hold cells together. Well, it can be on both, but they're holding the cells together and it's on both sides, whereas the hemidesmosome, it's just anchoring to the basement membrane.
So is the desmosomes doing that at the bottom half and tight junctions are doing the same thing at the top half?
I don't know.
Because it's on the side too, I thought.
Tight junction, they differ in function, I believe. Brady, help. Tight junctions are going to hold it together. Okay, now I'm confusing myself.
All right, so they all do pretty much the same thing on the side of the cell. They just have different components to it. So like I said earlier, the tight junctions are like glue. They don't let paracellular transport. Fluid can't get through between the cells. Right, but then the macula adherent, or the zonula adherents are like tie wraps. They hold the cell together. The desmosomes are like a spot weld. They're really small, but they're really strong. And the hemidesmosomes are similarly on the bottom. But yes, the three of those, the zonula, occludins, adherents, and desmosomes are all on the side of the cell, connecting cell to cell, and the hemidesmosomes are on the bottom, connecting the cell to the basement membrane.
Yeah. Those are confusing. I know it took a little bit for me to sit down and learn it in term one. You guys are all getting this correctly. It's B, I can't say the word, but S secretes C cell, and so that's how you can tell the difference between A and B. So since we are secreting HCG, we are talking about cociotrophoblasts. I've had a lot of people reach out about this question, but I'll explain why the answer is what it is. At one point when we first started it was wrong. It was keyed wrong. And so but we're going to talk about the correct answer here. You guys are getting it correct. Yeah, you guys are getting it correct. The answer is 9 + 2. Some people get confused with this because Cartaginer syndrome is also known as primary ciliary dyskinesia. And so you think it's primary cilia, which is 9+0. Primary cilia are sensory cilia. And they are 9, and that's why it's 9+0, because that 0 is the singlet in the middle. So the absence of the singlet in the middle means it has no motor action, versus 9+2, that 2 is the singlet in the middle, that is the motor action. So you have the dynein and kinesin arms. So Cartaginer syndrome is a defect in the dynein arm. And so you have a defect in the motor ability of the cilia. This is just your cilia. It's not primary cilia. This is just cilia, your motor cilia. And so Cartaginer syndrome is really bad because all of your cilia, the dynein arm is dysfunctional, meaning you don't have the motor component of the cilia, which is really important. So for example, in your respiratory tract, you have the motor, you have the cilia lining the pathway, which sweep up anything that shouldn't be there. So any mucus buildup, like when you cough, you can cough up mucus and any pollutants. And so people with Cartaginer syndrome very often have repeated respiratory infections because the cilia in their respiratory tract can't push any excess mucus or pollutant up. And so it builds up in the respiratory system. You can get an obstruction because of the mucus, and you can get increased infections because you have the mucus there. So Cartaginer syndrome is a big issue, but it's 9+2. The reason it's called primary ciliary dyskinesia, you'll learn about the difference between primary and secondary diseases in term 2 with ER. Primary means at the level of the organ versus a disease that is caused somewhere else. So that's why it's called primary ciliary dyskinesia. Please don't think that means it's primary cilia, because it is not. It is motor cilia. And then I just put this on here, things you need to know. This first point is a very small point, but it was on your exam, and it's not something I focused on when I was studying. So process of DNA methylation, all of these terms have a kind of basis overview of what they are. Major groups of amino acids, we didn't go over that today, but there are a handful in each of these. That is the big high yield point from that entire, I don't remember if it was a DLA or a lecture, but please know the different groups of amino acids. Pro versus anti-apoptotic proteins, Prader-Willi versus Engelmann's. Brady did a really good job of going over that. Please know the difference between the two. And then all genetic disorders and inheritance patterns. I think I've said that about 5 times during this, so you know that it's really important. You gotta identify, and you also need to be able to identify the disorders from the patient presentation, because they won't always diagnose the patient for you. You are going to have to do that based off of the signs and symptoms. Yes, question?
I don't know if they talk too much about MECP2. Can you just describe what that is?
Not going to lie to you, I do not remember, because I haven't looked at that since term 1, but I put it on this slide to Brady.
Yeah, there's go ahead. Yeah, go ahead. Yeah.
Oh, that it just
recruits
H-stack.
Right, they're all in a complex together. They're all in a complex together that help with methylation.
Yeah, so. They're definitions, honestly. The reason I put this on here is to tell you to go to your slides and look at it. Spend 2 to 3 minutes on it. It's definitions. It's not really conceptual. Just I don't want you guys to skip over it, because I almost skipped over it when I was studying, and I would have lost a point if I had. Yes. Did you still have a question?
Hey, I have a question.
Yeah, go for it.
I don't know how you guys had your exam. Like, I don't know if you guys had blocks too, like, because for our exam we have 3 blocks. Do you guys know how the blocks are? The blocks like lecture based, or are they like all over the place? Are like, will the questions from block 1 be like?
Oh no,
they're all mixed up.
Random. It's random.
It's all random. Yeah.
Okay. Thank you.
What do I mean by pro versus anti-apoptotic? There are some proteins that will induce apoptosis and some proteins that are anti-apoptosis. Know those. They're really just definitions.
Can we get calculators with us into the exam?
No.
Say that more. What?
No, you can't. You have to use the calculator based on the program.
Yeah.
On the exam soft program.
You cannot have anything with you, anything. People with smartwatches, take them off, because if the AI sees it, it is going to flag you. And if you are on campus, they will not let you into the testing center with it.
Quick question, can Brady repeat the means of transports for SGLT and GLUT?
Yeah, so the GLUT transporters are facilitated diffusion and the SGLTs are secondary active transport. Anything that has diffusion is not limited by ATP. If it's an active transport system, it has to use ATP to work. So that's the difference between diffusion versus active transport.
Thanks.
No problem.
Those who have,
all right.
Cheyenne, you had a question?
Yeah, just difference between SGLT1 and 2.
I'd have to look it up, to be honest with you. They're just probably located in different areas. I think SGLT2 is in the, I don't know, in the gut,
think
right?
SGLT1 is, I think, in the enterocytes, and the second one, I think, is in the kidneys.
Okay.
Okay. Yeah.
I don't remember that being a
There's a table in the PowerPoints with where it works.
Okay.
Thank you, guys.
Right. And then
Yeah,
also,
you're welcome.
Yeah.
Good luck.
Okay.
Thanks, guys. This was awesome. Really appreciate all the effort you put together to do this.
Yeah, you're welcome.
Yeah, no worries.
Yeah, it was a
Glad to
big help. Thank you so much, guys. Thank you.
Thanks,
Thank you very
everyone.
much.
Let us
I'll
know
try
if
to get
you guys need anything.
I'll try to get the recording posted if y'all need to go back to it. I'll get it posted in an hour or two when it uploads. Just remember, stress is normal. That means you care. It's okay. Don't let it consume you. All right. It's okay. You know more
Get
than
a
you
good night's
realize.
sleep.
Trust yourself. You know what you're doing. This is all a learning experience. So
Yeah, and also one bad test grade does not a failure make. So if you bomb this exam or you don't do as well as you wanted, that does not mean that you have just destroyed your medical school career. It doesn't mean that you will have to work a little more to revise your study habits and move forward. Yes, it does. But you can come back from a bad test grade. I have seen it done. I've mentored many a person who did not do well on the first exam and still pass the term. So do the best you can. Eat something tonight. Get something good to eat in the morning. Get a good night's rest. Please don't pull an all-nighter. That will not help you.
Nope. These tests take a lot of thought. So you need to be able to have a good night's sleep for sure. It's not undergrad anymore. So
yeah.
All right. I'm gonna stop
Also
the recording.
trust yourself.
Yeah.
You guys know more than
what
you
you're
think you do. You guys know a lot more than you think you do. And if you get stuck on a question, just flag it and move on. Don't waste more time working yourself up into a tizzy, because you're going to waste time that you could have spent on other questions, because there are going to be the ones that come easily. There are going to be the ones that you need to think a little bit more, and there are going to be the ones that you sit there for a few minutes and have to think about. So if you do come across the ones that stress you out, flag it, move on, come back to it later so that you can get as many points as possible. Ashley, did you just raise your hand?
Yeah, but I think the other student, oh, never mind, he lowered his hand. Yeah, I have a question in terms of, so we downloaded 3 blocks, right, for the exam,
yes.
And Exemplify. So do they give us a password for each block?
Yes. You'll get it
they
sent
will
out
email
about
it
right when you're supposed to start. Yeah.
Oh,
For each
okay,
one separately.
Yeah, so that was my next question. So like if we finish a block, I believe we have, let's say, like 20 to 30 minutes, I think, in between blocks. Do they tell us the start time for the other 2?
It should have been emailed to you
already.
Yeah, but they'll email it out when it's time to start. But yeah, you could check the email and it should say the starting time for each of the blocks.
Yeah, I think they email you about a week beforehand, and it'll say the check-in time for each.
Okay. Okay, thank you. And thank you so much for hosting this session. It's been very
Yeah,
helpful.
you're welcome.
No worries. All right. I'm going to stop the recording. As always, if y'all need anything, feel free to reach out. Good luck. Y'all will do great.